Welcome to this video entitled Gastrointestinal Disease. Let's begin with the gastrointestinal tract. The stomach is a J-shaped sac-like chamber that lies between the esophagus and small intestine. It is divided into three sections based on anatomical, histological and functional characteristics, as shown in Figure 1. Pause the video and carefully scrutinize Figure 1 illustrating the anatomical structure of the stomach before progressing to the next slide. The fundus is the portion of the stomach found above the esophageal opening. The main part of the stomach is the body. The lower portion is termed the antrum and the terminal part consists of the pyloric sphincter, which acts as a barrier between the stomach and the duodenum. The small intestine is the site at which most digestion and absorption take place. It is a tube about 6 meters long with a small diameter of 2.5 centimeters. It lies coiled within the abdominal cavity extending between the stomach and the large intestine, divided into three segments, the duodenum, jejunum and ileum, as shown in Figure 2. The large intestine consists of the colon, caecum, appendix and rectum, shown in Figure 2. The colon extracts water and salt from the chyme received from the small intestine. The colon consists of three relatively straight portions, the ascending colon, transverse colon, and descending colon. The terminal portion of the descending colon becomes S-shaped, forming the sigmoid colon, then straightens out to form the rectum. Rectum means straight. Pause the video and carefully scrutinize Figure 2 illustrating the gastrointestinal tract before advancing to the next slide. We will now discuss Helicobacter pylori and dyspepsia. Let's begin with peptic ulcer disease. There are two common forms of peptic ulcer disease, that associated with the organism Helicobacter pylori and that associated with the use of non-steroidal anti-inflammatory drugs, NSAIDs. This section will focus on the role of Helicobacter pylori in peptic ulcer disease, as clinical pharmacists are commonly required to advise on suitable eradication regimes. Next we will discuss Helicobacter pylori infection. Helicobacter pylori are spiral, gram-negative, microaerophilic, rod-shaped bacteria with multiple flagella. They were cultured in 1982 by pathologists Barry Marshall and Robin Warren, joint winners of the Nobel Prize in 2005 for the discovery of the bacterium and its role in gastritis and peptic ulcer disease, abbreviated as PUD. The bacterium was initially identified as Campylobacter pylori, and subsequent typing indicated that it was a new genus, Helicobacter. Multiple strains of Helicobacter pylori have since been identified. Helicobacter pylori are highly motile and have a unique ability to colonize the stomach, an environment usually hostile to microorganisms because of the acidic environment. The bacteria employ a number of techniques to survive this hostile environment. The bacterial cell produces urease which breaks down urea present in the host's gastric fluids. The product of this enzymatic reaction is ammonia, an alkali. Without urea, Helicobacter pylori is intolerant of an acidic environment. Helicobacter pylori also has a proton pump, similar to that found in parietal cells. This has the effect of removing hydrogen ions that get into the bacterial cell, thus avoiding acid accumulation within the cell. Helicobacter pylori prefer areas of moderate acidity and live in the mucus, close to the gastric mucosa. The gastric mucosa produces bicarbonate as part of the cytoprotective mechanisms, which effectively maintains the region adjacent to the gastric mucosal cells at a neutral pH. This preference for areas of moderate acidity is seen in the pattern in which the bacteria colonize the stomach. The antrum, an area in which there are relatively few parietal cells, is initially colonized. When acid secretion is suppressed, Helicobacter pylori are attracted to the corpus, which tends to be more acidic. Helicobacter pylori infect about 40% of adults in developed countries and up to 80% of the population in the developing world. They are strongly associated with greater age and with markers of overcrowding and poor hygiene in childhood. Infection is acquired by human contact. It is unknown whether oro-oral or FAECO-oral transmission is more important. Helicobacter pylori and peptic ulcer disease. Peptic ulcer is a breach in the gastric or duodenal mucosa of more than 5 mm in diameter, with associated inflammation. Small or shallow breaches are termed erosions. Next we will look at the incidence of PUD. The lifetime prevalence of PUD in the UK population is around 10%. There is a relative increase in PUD prevalence in the elderly population, which is believed to be due to a high incidence of Helicobacter pylori infection when this population was young. Peptic ulcer-related mortality also increases with age, mainly due to comorbid conditions. The overall incidence of PUD in the younger population is now decreasing in the developed world due to the decreasing prevalence of Helicobacter pylori infection. Duodenal ulcers, also known as DU, are 4 times more common than gastric ulcers, also called GU, and tend to occur in younger people. We will now discuss the pathogenesis of PUD. Only about 15% of patients infected with Helicobacter pylori develop a peptic ulcer. The risk of ulceration is higher with more virulent strains. The best described virulence determinants are expression of active forms of evaculating cytotoxin and possession of a protein secretory apparatus called CAG, which stands for cytoxin-associated gene products, that stimulates the host inflammatory response. Helicobacter pylori is present in about 90–95% of all cases of duodenal ulcers and 70–80% of gastric ulcers, and they are a risk factor for gastric cancer. Regardless of the site of colonization, first infection produces a temporary achlorhydria. Next we will discuss duodenal ulcers. In patients with duodenal ulcers, Helicobacter pylori infection is mainly confined to the gastric antrum, where gastrin and somatostatin are produced. Ammonia, produced by microbial urease, interacts with gastric acid to produce monochloroamines which stimulate gastrin release. Thus, Helicobacter pylori brings about an increase in circulating gastrin concentrations, which in turn increases acid and pepsin output. Somatostatin is an acid regulatory hormone secreted by specialized endocrine cells (D cells) in response to hydrochloric acid. Somatostatin inhibits acid secretion by a direct effect on parietal cells and also indirectly by decreasing gastrin release. Helicobacter pylori infection of the antral mucosa may lead to decreased number of D cells and thus somatostatin, causing increased acid secretion. It is well documented that there are significant physiological differences between patients with duodenal ulcers and those without ulcers. Patients with a duodenal ulcer have 1. Increased resting acid output, 2. Twice the number of parietal cells, compared with non-ulcer patients. 3. Prolonged acid secretion, which is indicative of an increased sensitivity of parietal cells to secretory stimuli. While Helicobacter pylori promote hyperplasia of the gastric mucosa, it is not clear whether this is responsible for the increase in parietal cell mass or if this is an inherited characteristic. Nevertheless, it appears that Helicobacter pylori infection will only proceed to ulcer formation in patients with a high parietal cell mass. Thus, these patients tend to be hypersecretors of acid. High acid levels pass into the duodenum where they induce gastric metaplasia. Helicobacter pylori, which cannot infect healthy duodenal mucosa, now can colonize the areas of gastric metaplasia, which may then progress to mucosal injury, and ulcer formation. Next we will discuss gastric ulcers. In contrast to duodenal ulcers, the predominant site of Helicobacter pylori colonization in gastric ulcers is the body of the stomach. Here, chronic Helicobacter pylori infection leads to corpus gastritis with atrophy and metaplasia of the gastric mucosa, which is a risk factor for gastric cancer. Thus, patients with gastric ulcers tend to have a lower than normal resting acid output, and this may be one reason why patients with corpus gastritis tend to have a lower incidence of GORD. These inflammatory changes weaken the mucosa, which may be further compromised by reflux of duodenal bile salts and digestive enzymes into the stomach, although this has not been universally accepted. Helicobacter pylori also secrete proteases and phospholipases which digest the protective mucus layer and cell membranes. In addition, the microorganism causes activation of platelet aggregation factor, abbreviated as PAF, which may lead to local hypoxia in the stomach and mucosal breakdown. We will now discuss its complications. It is estimated that 1/3 of patients with a confirmed ulcer experience at least one complication during their life. The major complications are 1. Bleeding, 2. Perforation, and 3. Obstruction. Regarding bleeding, 1/5 of all patients with PUD experience at least one episode of bleeding. This complication is responsible for 40% of deaths from PUD, and patients in greatest danger are those who have had more than one episode of bleeding. Causes of acute upper GI hemorrhage are shown in Table 1. Most cases, 95%, of upper gastrointestinal hemorrhage can be managed by medical means, including acid-suppressing drugs, and thermal hemostasis or injection therapy via endoscopy. Pause the video and carefully scrutinize Table 1 summarizing the causes of acute upper GI hemorrhage before advancing to the next slide. Next we will discuss about perforation. The risk of perforation increases with age. 5 to 10% of patients presenting with duodenal ulcers perforate, while only 2 to 5% of those with gastric ulcers experience this complication. 1 in 7 patients who perforate will die. Regarding obstruction, ulcers may induce inflammation, spasm and fibrosis, which can result in narrowing of the stomach or duodenum at the site of the ulcer. This is most often seen in the pyloric canal and may ultimately cause gastric outlet obstruction. The condition may respond to endoscopic pyloroplasty, balloon dilatation, although surgery is usually required in patients with frequent recurrence. The possibility of obstruction due to neoplasm must not be overlooked. Next we will discuss its diagnosis. We will begin with testing in primary care. Guidelines for managing dyspeptic patients in primary care recommend the use of non-invasive tests for Helicobacter pylori detection. This approach has been demonstrated to be clinically effective and less costly than invasive testing. Several non-invasive tests for Helicobacter pylori are available for use in primary care, avoiding the need for endoscopy and biopsy to confirm infection. 1. Carbon-13, 13C, urea breath tests or UBT. 2. Stool antigen tests. And 3. Serological tests. Let's begin with urea breath test, UBT. This test depends on the production of urease by Helicobacter pylori. The patient drinks radiocarbon-labeled urea. If urease is present in the upper GI tract, the ingested urea is broken down to ammonia and labeled carbon dioxide appears in the breath, as shown in Figure 3. Pause the video and carefully scrutinize Figure 3, which illustrates the chemistry of the urea breath test. The diagnostic accuracy is over 95% in studies. Patients should fast for at least 6 hours before urea breath test. Next we will discuss the stool antigen tests. Stool tests detect the specific Helicobacter pylori antigen. It is necessary to store stool samples at -20 degrees Celsius before testing, and thus availability varies across the UK. In a systematic review of 89 studies evaluating the stool antigen test, the sensitivity and specificity were 91% and 93%, respectively. Next we will discuss serology. Serology testing for the presence of antibodies to Helicobacter pylori is a convenient test of Helicobacter pylori infection for patients who are not undergoing endoscopy. While relatively simple to use without the need for specialized equipment, the various tests available display a wide range of sensitivities 60 to 100% and specificities 47 to 96%. Regarding the test of choice, NICE recommends the use of either a UBT or a stool antigen test for pre-treatment testing. However, serology is still widely used. Stool antigen tests and UBT cost more to perform than laboratory-based serological tests, but any additional cost to the healthcare provider will be offset by improved diagnostic accuracy. Where it is necessary to retest to confirm eradication of Helicobacter pylori, this should generally be performed no sooner than 4 weeks after the completion of treatment, and the UBT should be used. There is currently insufficient evidence to support use of the stool antigen test as a test of eradication. Serological tests cannot be used to confirm eradication because the antibody can persist for up to 2 years after successful eradication. Next we will discuss endoscopy. Endoscopy allows for biopsy Helicobacter pylori testing, either by urease testing or histology. Biopsy urease testing. This test is dependent on the production by Helicobacter pylori of urea, which being alkaline, brings about a change in the pH indicator phenol red from yellow to red. There are numerous tests available that employ this methodology, the most commonly used commercial test being the CLO test. The CLO test requires 1 or 2 biopsy samples to be pushed into the test gel, which is then observed for 24 hours. A color change from yellow to pink, red at 1, 3, and 24 hours indicates a positive result. False positive results may occur after 24 hours. The specificity of this test is 97% with a sensitivity of 75% at 20 minutes, 90% at 3 hours and 95% at 24 hours. It is important to note that false positive results can occur if the patient's intragastric pH is close to neutral, as these conditions may facilitate the proliferation of other urea-producing bacteria, such as Proteus species. Conversely, false negative results may be due to concomitant therapy or sampling problems. Sampling errors occur because the distribution of Helicobacter pylori is not uniform within the stomach, and such errors are minimized by taking multiple samples. PPIs have a weak antibacterial action and also inhibit urease, thereby interfering with tests that depend on the secretion of urea. Accordingly, UBT, stool antigen tests and endoscopy should not be performed within 2 weeks of PPI or H2 receptor antagonist therapy or within 4 weeks of antibiotic therapy. Next we will discuss its histology. While less convenient than urease testing, histology enables direct visualization of Helicobacter pylori. The biopsy sample is fixed in formalin and stained with acridine orange or Giemsa. Under microscopy, Helicobacter pylori are visualized as S-shaped microorganisms 3 to 4 micrometers in length. This method has a sensitivity of 85% and specificity close to 100%. We will discuss eradicating Helicobacter pylori. Patients who are positive for Helicobacter pylori and whose PUD is not associated with NSAID use should be offered eradication therapy. Patients who are negative for Helicobacter pylori should receive full-dose PPI for 1 or 2 months. Patients with gastric ulcers always require repeat endoscopy and biopsy to confirm healing and exclude malignancy. If symptoms persist in a patient with duodenal ulcers, other causes of the ulcer should be investigated. Management flowcharts, NICE guidance, for patients with gastric ulcers and duodenal ulcers are shown in figures 4 and 5. Pause the video and carefully scrutinize figure 4 summarizing the management flowchart for patients with gastric ulcer, from NICE guideline CG17 dyspepsia before advancing to the next slide. 1. If NSAID continuation is necessary, after ulcer healing, offer long-term gastric protection or consider substitution to a newer COX-2 selective NSAID. 2. Use a carbon-13 urea breath test, stool antigen test or, when performance has been validated, laboratory-based serology. 3. Use a PPI amoxicillin, clarithromycin 500 mg, abbreviated as PAC 500, regimen or a PPI, metronidazole, clarithromycin 250 mg, abbreviated as PMC 250, regimen. Follow guidance found in the British National Formulary for selecting second-line therapies. After 2 attempts at eradication, manage as Helicobacter pylori negative. 4. Perform endoscopy 6 to 8 weeks after treatment. If retesting for Helicobacter pylori, use a carbon-13 urea breath test. 5. Offer low-dose treatment, possibly used on an as-required basis, with a limited number of repeat prescriptions. 6. Review care annually, to discuss symptoms, promote stepwise withdrawal of therapy when appropriate and provide lifestyle advice. In some patients with an inadequate response to therapy, it may become appropriate to refer to a specialist. Pause the video and carefully scrutinize figure 5 summarizing the management flowchart for patients with duodenal ulcer, from NICE guideline CG17 dyspepsia, before advancing to the next slide. 1. If NSAID continuation is necessary, after ulcer healing, offer long-term gastric protection or consider substitution to a newer COX-2 selective NSAID. 2. Use a carbon-13 urea breath test, stool antigen test or, when performance has been validated, laboratory-based serology. 3. Use a PPI amoxicillin, clarithromycin 500 mg, also known as PAC 500, regimen or a PPI, metronidazole, clarithromycin 250 mg, also called PMC 250, regimen. 4. Use a carbon-13 urea breath test. 5. Follow guidance found in the British National Formulary for selecting second-line therapies. 6. Offer low-dose treatment, possibly on an as-required basis, with a limited number of repeat prescriptions. 7. Consider non-adherence with treatment, possible malignancy, failure to detect Helicobacter pylori infection due to recent PPI or antibiotic ingestion, inadequate testing or simple misclassification, surreptitious or inadvertent NSAID or aspirin use, ulceration due to ingestion of other drugs, Zollinger-Ellison syndrome, Crohn's disease. 8. Review care annually, to discuss symptoms, promote stepwise withdrawal of therapy when appropriate and provide lifestyle advice. Next we will discuss the benefits of Helicobacter pylori eradication. Eradication of Helicobacter pylori has been shown to increase the rate of healing of duodenal ulcers compared with acid suppression alone. Healing of gastric ulcers is not increased by Helicobacter pylori eradication. The principal benefit of eradication is reduction in ulcer recurrence rates, thereby removing the need for long-term acid suppression therapy. Of patients with duodenal ulcers, 39% of those receiving short-term acid suppression will be free from ulcers after 3 to 12 months. Eradication increases this by 52% with an NNT equal to 2. For gastric ulcers, the equivalent figures are 45% with acid suppression, increased by a further 32% by eradication, with an NNT equal to 3. Next we will discuss the choice of eradication regimen. Helicobacter pylori eradication is achieved by a combination of antibiotic therapy and acid suppression. Various combinations of dual, triple, sequential, 1 and 2 week therapies have been used, and the efficacy of these is reviewed in the full NICE guideline. NICE guidance for first-line therapy is a 7-day, twice-daily course of 1. A full-dose PPI plus 2. Clarithromycin, plus either 3. Metronidazole, known as the PMC 250 regimen, or amoxicillin, known as the PAC 500 regimen. A dose of 500 mg clarithromycin rather than 250 mg has been shown to give higher eradication rates in the PAC regimen, while for the PMC regimen 250 mg clarithromycin is as effective as 500 mg. Data for these regimens indicate that they are effective in 80 to 85% of patients and show no statistically significant difference in eradication rates. Increasing the course length to 14 days increases eradication rates by about 10%, but this was not found to be cost-effective when modeled by NICE. An alternative antibiotic should be used in the eradication regimen if a course of clarithromycin or metronidazole has previously been given, for any indication, within the last year. Resistance of Helicobacter pylori to antibiotics, especially metronidazole and clarithromycin, is a problem, and its prevalence seems to be increasing. Laboratory testing suggests that Helicobacter pylori antibiotic resistance is around 15 to 66% for metronidazole, and 8 to 30% for clarithromycin. Whether this increase is caused by antibiotic use in Helicobacter pylori eradication or by the prescription of antibiotics for other indications is not known. Should a patient remain positive for Helicobacter pylori after initial treatment, the Maastricht III Consensus Report 2005 recommends a quadruple drug regimen of full-dose PPI, tripotassium dicitratabismuthate, Donoltab, 120 mg 4 times daily, metronidazole 400 mg 3 times daily, and tetracycline 500 mg 4 times daily for 14 days. Two other classes of antibiotics are emerging in the second-line treatment of Helicobacter pylori, a fluoroquinolone, levofloxacin, and a rifamycin, rifabutin. The most important predictors of treatment failure following Helicobacter pylori eradication are antibiotic resistance, and poor compliance. It is critical for practitioners to stress the importance of taking the medication as prescribed. Patients should be informed of the most commonly reported treatment-related side effects. While mild side effects are very common with any of the recommended Helicobacter pylori treatment regimens, significant side effects are reported in only 5 to 20%. Informed patients are less likely to be alarmed when side effects that they are aware of occur and, consequently, less likely to needlessly stop their treatment. Next we will discuss inflammatory bowel disease. Inflammatory bowel disease, also called IBD, is a general classification and includes both ulcerative colitis, also called UC, and Crohn's disease, also known as CD. Both ulcerative colitis and Crohn's disease are chronic relapsing disorders that impact on educational, social, professional, and family life. While signs and symptoms are generally similar, there are pathophysiological differences between the two conditions that impact on disease prognosis and complications. Incidence and prevalence: a total of about 115,000 people have inflammatory bowel disease in the UK, and a total of approximately 2.2 million across Europe. The median population incidence of Crohn's disease is 6.7, range 1.6 to 14.6 cases per 100,000 annually in the West, and the prevalence of Crohn's disease in the UK is approximately 55 to 140 per 100,000 population. Putting this in perspective, most GPs in the UK will see a new case of Crohn's disease every 7 years. The incidence of ulcerative colitis is higher than Crohn's disease at about 10 to 20 cases per 100,000 annually, and the UK prevalence of ulcerative colitis is about 160 to 240 per 100,000 cases. The combined incidence of ulcerative colitis and Crohn's disease is about 13,300 new cases diagnosed each year. There is a peak in incidence of inflammatory bowel disease between the ages of 10 and 19 years, and a smaller peak beyond 50 years of age. Women may be at a slightly increased risk of Crohn's disease than men, whereas the risk for ulcerative colitis is the same for men and women. Next we will discuss the etiology of inflammatory bowel disease. The causes of ulcerative colitis and Crohn's disease are not fully known. Although they are thought to be autoimmune diseases, it is not certain whether autoimmune abnormalities are a cause or result of the diseases. Etiology may have a genetic, infectious, psychological, and immunological basis. Epidemiological studies have considered diet, drug and vaccination, e.g. measles, history, seasonal variation, water supply and social circumstances. Probably the most widely accepted hypothesis of inflammatory bowel disease is that it is the result of genetically determined defective immunosuppression resulting in an overly aggressive response to gut luminal contents. Sensitizing antigen or antigens activate cytotoxic T lymphocytes to produce antibodies and induce the inflammatory cascade evident in the gastrointestinal tract. This argument is given added weight by the clinical response of patients to corticosteroids and other immunosuppressive agents. The source of antigens remains the subject of much speculation. While the evidence for these hypotheses is incomplete, an immunological basis for the disease may also explain some of the extraintestinal manifestations. Suggested risk factors for ulcerative colitis include NSAID use and a family history of ulcerative colitis or Crohn's disease. Smoking has a protective effect on the development and severity of ulcerative colitis. Ex-smokers have about a 70% greater risk of developing ulcerative colitis, which is often more extensive and refractory than in those who have never smoked. Appendectomy has been shown in cohort studies and meta-analysis to provide some protection against subsequently developing ulcerative colitis and in reducing its severity if performed for true appendicitis at a younger age. In contrast, smokers have a greater risk of Crohn's disease than the general population. They also have a more severe course of Crohn's disease, require more immunosuppressive drugs, and the disease recurs more quickly after surgery. Stopping smoking may moderate the clinical course of Crohn's disease, although the greatest benefit of cessation is seen with the heaviest smokers. A diet high in fat or refined foods also increases the risk of developing Crohn's disease. Next we will look at definition and classification. Crohn's disease is a relapsing, patchy, transmural, that is involving the whole thickness of the intestinal wall, inflammatory disease of the gastrointestinal mucosa that can affect any part of the GI tract from mouth to anus. Typical findings include the discontinuous involvement of various portions of the GI tract, known as segmental inflammation or skip lesions, and the development of complications including strictures, abscesses, or fistulae. Numerous scoring systems are available for quantifying disease activity in Crohn's disease. The Crohn's Disease Activity Index, abbreviated as CDAI, and the Harvey-Bradshaw Index are research tools that have been widely used in clinical trials. In clinical practice, disease activity is typically described as mild, moderate, and severe, as shown in Table 2. Pause the video and carefully scrutinize it before advancing to the next slide. Crohn's disease can also be classified as localized, affecting less 30 cm of intestine, or extensive, affecting more than 100 cm, which applies to the sum of inflammation in discontinuous segments. There are three main patterns of disease distribution: 40 to 50% of patients present with a colonic disease, around 30% will have isolated small bowel disease, and another 30% will have disease confined to the colon. Much less commonly, Crohn's disease involves more proximal parts of the GI tract such as the mouth, esophagus, stomach and duodenum. Ulcerative colitis is a chronic inflammatory condition causing continuous mucosal inflammation of the colon without granulomas on biopsy, affecting the rectum and a variable extent of the colon in continuity, which is characterized by a relapsing and remitting course. Depending on the extent of involvement, patients can be classified as having proctitis, that is involvement limited to the rectum, left-sided colitis, involvement limited to the proportion of the colon distal to the splenic flexure, or extensive colitis, that is involvement extends proximal to the splenic flexure, including pancolitis. The extent of inflammation is important as this will influence the choice of delivery system for a given therapy, for example, whether oral and/or topical therapy is indicated. In clinical practice, the Truelove and Witts criteria is useful where disease activity is typically described as mild, moderate, and severe, as shown in Table 3. Remission means a stool frequency equal to or less than thrice daily with no bleeding and no urgency. Pause the video and carefully scrutinize Table 3 summarizing disease activity in ulcerative colitis adapted from Truelove and Witts before advancing to the next slide. Next we will discuss the clinical features of inflammatory bowel disease. We will begin with Crohn's disease. Chronic diarrhea is the most common presenting symptom in Crohn's disease. In colonic disease, especially involving the rectum, the diarrhea is of small volume and associated with tenesmus, constant sense of heavy discomfort about the lower bowel and desire to defecate, coupled with straining when doing so. Disease confined to the ileum causes large volume diarrhea, but no tenesmus or urgency. Severe terminal ileal involvement is associated with bile salt diarrhea which, in severe cases, can result in steatorrhea, that is passing of stools containing an excess of fat. Abdominal pain and weight loss are seen in about 70% and 60% respectively of patients before diagnosis. Blood and/or mucus in the stool may be seen in up to 40 to 50% of patients with Crohn's colitis, but less frequently than in UC. Extraintestinal complications are most common when Crohn's disease affects the colon. Perianal fistulas are present in 10% of patients at the time of diagnosis. Next we will discuss ulcerative colitis. The primary presenting symptom of ulcerative colitis is bloody diarrhea and is reported by more than 90% of patients. Patients with extensive active ulcerative colitis will also describe rectal urgency, tenesmus, passage of mucus, nocturnal diarrhea and crampy abdominal pain, or ache over the left iliac fossa prior to and relieved by defecation. However, patients with proctitis may have little diarrhea and occasionally severe constipation. The onset of ulcerative colitis is usually insidious but may present as a severe attack, in about 15% with systemic symptoms including weight loss, abdominal pain, fever and tachycardia, or nausea and vomiting. Extraintestinal complications occur at presentation in about 10% and rarely precede intestinal symptoms. Next we will look at general signs and symptoms. Inflammation that leads to diarrhea in inflammatory bowel disease reduces the functional capability of the GI tract, thereby decreasing nutrient uptake. In severe cases, patients may appear malnourished. In addition to weight loss, an early sign of decreasing nutrient uptake is hypoalbuminemia, that is low serum albumin. Although malabsorption and increased resting energy expenditure may contribute to malnutrition, decreased oral intake, due to anorexia, is the primary cause. Additional deficiencies include calcium, zinc, magnesium, phosphate, folate and vitamins, including vitamin B12. Chronic and untreated diarrhea may also contribute to weight loss as transit times decrease, allowing insufficient time for nutrient absorption. Diarrhea can also result in the patient becoming dehydrated and losing potassium, eventually producing hyperkalemia. In ulcerative colitis, the colonic mucosa becomes fragile, which leads to rectal bleeding and thus bloody diarrhea. Inevitably, this may produce anemia that will be exacerbated by folate deficiency, and iron and vitamin B12 malabsorption. A low-grade fever, fatigue and malaise, frequently accentuated by anemia, often accompany these findings. Next we will discuss diagnosis of inflammatory bowel disease. A gold standard for the diagnosis of inflammatory bowel disease is not available. The diagnosis of ulcerative colitis or Crohn's disease should be established by a combination of medical history, clinical evaluation, typical endoscopic and histological findings and negative stool tests for infectious agents. Loose stools, or a decrease in stool consistency, for more than 6 weeks helps differentiate inflammatory bowel disease from most infectious diarrhea. Laboratory findings in inflammatory bowel disease are largely nonspecific. Every patient with active disease at presentation should have a full blood count (FBC), inflammatory markers (CRP and ESR), electrolytes and liver function tests, along with a stool sample for microbiological testing, Clostridioides difficile toxin A and B, Campylobacter species, and Escherichia coli 0157H7, and plain abdominal X-ray. The FBC may reveal thrombocytosis as a result of the chronic inflammatory response, anemia indicating disease severity or chronicity, and leukocytosis. A moderately elevated leukocyte count is indicative of disease activity, whereas a marked elevation suggests the presence of an infection or, in Crohn's disease, of an abscess or other complication. CRP broadly correlates with clinical activity, excluding proctitis. An elevated CRP is generally associated with an elevated ESR, anemia and hypoalbuminemia. The ESR is usually higher in active colonic disease than in ileal disease. Endoscopy is the most useful investigative tool for inflammatory bowel disease, enabling visualization of the intestinal mucosa and allowing mucosal biopsy. The characteristic continuous mucosal inflammation seen at sigmoidoscopy enables a reasonably confident diagnosis of ulcerative colitis to be made before biopsy results become available. Colonoscopy is more useful, but not initially necessary, in defining disease extent in ulcerative colitis. Colonoscopy is valuable in the investigation of Crohn's disease, enabling visualization and biopsy of patchily distributed colonic disease and often revealing characteristic terminal ileal involvement. We will now move on to differences between ulcerative colitis and Crohn's disease. The major differences between ulcerative colitis and Crohn's disease are summarized in Table 4. Pause the video and carefully scrutinize it before advancing to the next slide. Next we will discuss the complications of inflammatory bowel disease. Complications of inflammatory bowel disease may be classified as intestinal or extra-intestinal. Next we will discuss intestinal complications. Toxic megacolon is more commonly associated with severe ulcerative colitis and implies that inflammation has spread into the muscle layers of the transverse colon so that it is dilated more than 6 centimeters. Distension of the colon is caused by loss of motility through inflammation, diarrhea-induced hyperkalemia and, occasionally, by the use of opiates. It constitutes a surgical emergency because of the risk of perforation and carries a mortality rate of 50%, although perforation can occur in the absence of megacolon. Abscesses may occur in Crohn's disease because of the increased permeability of the affected gut to microorganisms. Treatment involves surgical drainage of the abscess coupled with aggressive antibiotic therapy. Fistulae, channels between the bowel and the skin or between the bowel and another organ, such as the bladder, occur more commonly in Crohn's disease and are treated by surgical intervention. Fistulae may close spontaneously in some patients as a result of bowel rest, when nutrition is provided by the parenteral route. While bleeding is frequently seen in ulcerative colitis, major life-threatening hemorrhage is uncommon in either form of inflammatory bowel disease. 10% of patients with Crohn's disease will develop strictures, and these are caused by either the inflammatory processes or carcinoma. If left untreated, a stricture may proceed to bowel obstruction. Patients with ulcerative colitis and Crohn's colitis carry an increased risk for developing colorectal cancer (CRC). Patients with more extensive colitis, greater duration of disease, concomitant primary sclerosing cholangitis, and a family history of CRC are at greater risk among ulcerative colitis patients. Young age at disease onset and greater inflammatory burden have also been proposed as risk factors. Screening for CRC is thus offered to all patients with long-standing, extensive ulcerative colitis or Crohn's colitis. Next we will discuss extra-intestinal complications. Extra-intestinal complications, as shown in Table 5, occur in up to 30% of patients affected by inflammatory bowel disease, although this is probably an overestimate. The occurrence of one extra-intestinal complication, abbreviated EIC, appears to predispose to others, and female patients with colitis, either ulcerative or Crohn's colitis, appear to be particularly susceptible. Extra-intestinal complications may or may not follow the clinical activity of the underlying inflammatory bowel disease. Pause the video and carefully scrutinize Table 5 summarizing the extra-intestinal complications of inflammatory bowel disease before advancing to the next slide. Pause the video and carefully scrutinize Table 5 summarizing the extra-intestinal complications of inflammatory bowel disease before advancing to the next slide. Next we will discuss the medical management of inflammatory bowel disease. Ulcerative colitis responds better to medical management than does Crohn's disease. Therapeutic decisions in inflammatory bowel disease depend on disease activity and extent. Patients with severe disease require hospital admission, whereas those with mild or moderate disease can generally be managed as outpatients. Recent European ECCO guidelines are based on systematic reviews and expert consensus. They recommend that treatment is conceptualized in terms of induction and maintenance of remission. In ulcerative colitis, lifelong maintenance therapy is generally recommended for all patients and may reduce the risk of developing CRC. Maintenance therapy may be less effective in Crohn's disease, where smoking cessation is probably the most important factor in maintaining remission. A summary of agents used in the management of inflammatory bowel disease is shown in Tables 6 and 7. Pause the video and carefully scrutinize Table 6 summarizing medical management of Crohn's disease before advancing to the next slide. Pause the video and carefully scrutinize Table 7 summarizing medical management of ulcerative colitis before advancing to the next slide. Next we will discuss aminosalicylates in inflammatory bowel disease. Sulfasalazine is the parent aminosalicylate and has been in use for over 40 years. Sulfasalazine is a combination of 5-aminosalicylic acid, abbreviated as 5-ASA, also known as mesalazine, and sulfapyridine. Of these, 5-aminosalicylic acid has been found to be the therapeutically active compound, while sulfapyridine acts as an inert carrier molecule. Unbound or uncoated 5-aminosalicylic acid is readily absorbed in the upper jejunum and is unable to reach the colon in therapeutic concentrations. Despite its benefits, 10 to 45% of people receiving sulfasalazine have reported adverse effects. These are due to the sulfapyridine moiety, especially those effects found to be dose-dependent. Research aimed at finding alternative 5-aminosalicylic acid delivery systems resulted in the development of numerous 5-aminosalicylic acid formulations that are available as oral tablets, sachets, suspension, liquid or foam enemas, or suppositories. The choice of aminosalicylate is debated, but is influenced by tolerability, dose schedule and cost. A systematic review showed no differences between aminosalicylates in absorption and systemic exposure to 5-aminosalicylic acid. Efficacy may depend more on adherence with the prescribed dose than the delivery system. Oral mesalazine is commonly given as a modified release preparation, as shown in Table 8, to target topical exposure to the diseased area of the bowel. Available formulations have differences in licensed indications, tablet strengths, pharmaceutical, pharmacological and pharmacokinetic properties, and so products should be matched to the site of disease and are not interchangeable. Although the exact mechanism or mechanisms of action of aminosalicylates in inflammatory bowel disease remains to be determined, they are thought to act on epithelial cells to moderate the release of lipid mediators, cytokines, and reactive oxygen species. Pause the video and carefully scrutinize Table 8 summarizing formulation and delivery details of aminosalicylates before advancing to the next slide. Next we will discuss their role in Crohn's disease. In Crohn's disease, aminosalicylates have been used for over 3 decades to treat mild to moderate disease activity, and there is some evidence for the prevention of post-operative recurrence. Induction since 2006, important findings have emerged about the value of mesalazine in Crohn's disease. For mild or moderately active Crohn's disease, mesalazine seems little better than placebo, but it is widely used in clinical practice. Opinion varies about the value of topical 5-aminosalicylic acid as adjunctive therapy in left-sided colonic Crohn's disease. There has been no controlled trial of topical therapy in Crohn's disease, so there is no evidence base. It is occasionally used in difficult cases of distal Crohn's disease. Next we will discuss maintenance. Although oral aminosalicylates are widely used for the maintenance of medically induced remission in Crohn's disease, this practice is not evidence-based. 5-aminosalicylic acid is considered clinically no more effective than placebo for active ileal or colonic Crohn's disease. We will now discuss their role in ulcerative colitis. Aminosalicylates are first-line therapy for inducing response and remission in patients with mild to moderate ulcerative colitis and for maintaining remission in ulcerative colitis. Regarding induction, topical, rectal administration is effective in proctitis and left-sided ulcerative colitis. Oral aminosalicylates should be added to topical therapy in patients with left-sided or extensive ulcerative colitis. Controversy exists about the optimum induction dose in active ulcerative colitis. Higher doses, 2 to 4 grams per day, can result in an increase in absolute response rates of about 10%. In severe ulcerative colitis, aminosalicylates should be avoided as they can cause diarrhea, thus affecting the monitoring of therapeutic response and decision to proceed to colectomy. Next we will discuss maintenance treatment. Oral aminosalicylates are the first-line maintenance treatment in patients responding to 5-aminosalicylic acid or steroids, administered either orally or rectally. Maintenance with topical mesalazine is a valuable alternative in proctitis and left-sided ulcerative colitis. A combination of oral and rectal aminosalicylates can be used as a second-line maintenance treatment. The minimal effective dose of oral mesalazine is around 1 gram per day. For rectal treatment, 3 grams per week in divided doses is sufficient to maintain remission. The dose can be tailored individually according to response, and in some cases higher doses, 2 to 4 grams per day plus minus topical mesalazine, may be useful. Next we will discuss side effects and monitoring. Side effects such as headache, nausea, epigastric pain, and diarrhea are most common with aminosalicylates and are dose-related. Serious idiosyncratic reactions, including Stevens-Johnson syndrome, pancreatitis, agranulocytosis, or alveolitis, are generally avoided by using 5-aminosalicylic acid rather than sulfasalazine. Renal impairment with aminosalicylates is also rare. The risk of renal impairment appears to be associated with disease severity rather than the dose or type of aminosalicylate. Impairment of male fertility is well documented with sulfasalazine, and is mainly due to the sulfapyridine moiety. The seminal fluid abnormalities, that is oligospermia, reduced sperm motility, and abnormal forms associated with sulfasalazine can be reversed by changing to a different aminosalicylate. All aminosalicylates can cause blood dyscrasias, although these are rare. Treatment should be stopped if blood dyscrasia occurs. Since hematological complications are very rare amongst people with inflammatory bowel disease treated with an aminosalicylate, formal monitoring of full blood count is not warranted. However, patients should be warned to seek medical attention if they develop symptoms such as fever, rash, severe mouth ulcers or severe sore throat, in which case the full blood count should be checked. People with pre-existing renal impairment, other potentially nephrotoxic drugs, or comorbid disease should have renal function monitored during therapy whilst they are taking an aminosalicylate. Next we will discuss corticosteroids in inflammatory bowel disease. Steroids have been used in the management of inflammatory bowel disease for many years and are highly effective in the induction of remission of both Crohn's disease and ulcerative colitis, with a response rate of 70 to 75%. Corticosteroids have multiple actions in reducing the inflammatory cascade, through inhibition of the immune system and the blockade of prostaglandin and leukotriene production. The usual dose of oral prednisolone is 40 mg per day, a dose which is a reasonable compromise between efficacy and adverse effects. Oral prednisolone should be reduced gradually, by 5 mg every 7 days, over about 8 weeks. More rapid reduction can be associated with early relapse. Doses below 20 mg are not generally effective in active disease states. A new generation of corticosteroids, budesonide, beclometasone, with enhanced receptor affinity and increased potency are becoming available for the management of inflammatory bowel disease. Budesonide exhibits 200 times the affinity for the corticosteroid receptor compared with hydrocortisone and 50 to 100 times compared with prednisolone, while demonstrating only 10 to 15% systemic bioavailability. Compared to prednisolone, budesonide causes less acne and less moon faces. It does not impair bone metabolism and does not result in osteoporosis. Despite having less systemic activity than conventional corticosteroids, budesonide does have suppressive effects on adrenal function and should not be stopped abruptly or used as long-term treatment. While there is some evidence that it may cause fewer systemic side effects, it is less effective than prednisolone, and is considerably more expensive. Next we will discuss the role in Crohn's disease. Regarding induction, 2 major trials, the National Cooperative Crohn's Disease Study and the European Cooperative Crohn's Disease Study, established steroids, that is prednisone, as effective therapy for inducing remission in Crohn's disease. Oral budesonide 9 mg daily is effective in inducing remission in people with mild to moderate active CD in the ileum and/or ascending colon. Regarding maintenance treatment, steroids are ineffective in maintaining remission in Crohn's disease. However, some patients with Crohn's disease do seem to have fewer flare-ups if they are maintained on low-dose 5 mg prednisolone. Next we will discuss the role in ulcerative colitis. Regarding induction, topical steroids should be reserved as second-line therapy for patients with proctitis who are intolerant of topical mesalazine. They may be combined with topical or oral mesalazine for escalation of therapy. Moderately active ulcerative colitis that either does not respond to aminosalicylates or occurs in patients who are already taking appropriate maintenance therapy requires treatment with oral steroids. Clipper is a new beclometasone 5 mg tablet that is licensed for the treatment of mild or moderate ulcerative colitis in the active phase, as add-on therapy to aminosalicylates. A combination of oral and rectal steroids is better than either alone. Intravenous corticosteroids remain the mainstay of conventional therapy for acute severe colitis. Patients should be treated in hospital with intravenous hydrocortisone 100 mg 4 times daily. Higher doses are no more effective, but lower doses are less effective. Bolus injection is as effective as continuous infusion. Treatment is usually given for 7 days since extending therapy beyond this carries no benefit. Regarding maintenance treatment, steroids are ineffective in maintaining remission in ulcerative colitis. Once remission has been achieved, steroids should be reduced and stopped if possible. Next we will discuss the side effects. Whilst the short-term use, less than 3 weeks, of prednisolone with doses of less than 60 mg daily results in few side effects or adrenal suppression, the cumulative dose used in people with inflammatory bowel disease is often larger than this, and they are commonly treated with many doses over several years. Topical corticosteroids in the form of enemas and foams are commonly employed in the management of distal colitis. Agents such as hydrocortisone enemas may demonstrate significant systemic absorption and bioavailability. Depending on the degree of inflammation and time of mucosal contact, more than half of the dose may be absorbed. Next we will discuss the thiopurines in inflammatory bowel disease. Thiopurines, that is azathioprine and mercaptopurine, are effective for both active disease and maintaining remission in Crohn's disease and ulcerative colitis. A Cochrane review of the efficacy of thiopurines for inducing remission in active Crohn's disease suggested a number needed to treat, abbreviated as NNT, of 5 and a number needed to harm, abbreviated as NNH, of 14. Their efficacy at maintaining remission is confirmed in another Cochrane review where the NNT was 7 and the NNH was 19. However, thiopurines have a slow onset of action and this precludes their use as sole therapy. Instead they are introduced once a patient has been stabilized using steroids, which are then reduced or withdrawn after 2 or 3 months. The main role for thiopurines is thus steroid-sparing NNT of 3, first-line maintenance therapy in Crohn's disease, where no therapy is not an option or aminosalicylates have failed, and second-line maintenance therapy in ulcerative colitis. Thiopurines should be considered for patients 1. who require 2 or more corticosteroid courses within a year. 2. whose disease relapses as the dose of oral steroid is reduced below 15 mg daily. 3. who relapse within 6 weeks of stopping steroids, or for 4. Postoperative prophylaxis of complex, that is fistulizing or extensive Crohn's disease. Thiopurines are continued for at least 5 years, and increasing the duration of treatment will keep patients in remission for longer. Azathioprine is used at doses of 2 to 2.5 mg per kilogram per day and mercaptopurine at 1 to 1.5 per kilogram per day. No direct comparisons of the efficacy of azathioprine and mercaptopurine in inflammatory bowel disease exist. Neither drug is licensed for the treatment of inflammatory bowel disease. The bioavailability of mercaptopurine is variable, and may be improved with evening administration of the dose. Azathioprine is essentially a prodrug, and after oral administration, most azathioprine is converted to mercaptopurine within red blood cells. As purine antimetabolites, thiopurines inhibit RNA synthesis, but the mechanism for the therapeutic effect is largely unknown. It is proposed that they modulate cell signaling by inducing T-cell apoptosis. Next we will discuss side effects and monitoring. Side effects that limit thiopurine use occur in 10 to 25% of patients. Once the drug is tolerated for 2 to 3 weeks, long-term benefit can be expected. Some patients who are intolerant of azathioprine may tolerate mercaptopurine. Minor side effects include commonly experienced but reversible flu-like symptoms, such as myalgia, headache, and diarrhea, and nausea, which characteristically occur in weeks 2 to 3 of treatment, and do not necessitate treatment withdrawal. Major side effects include bone marrow suppression with leukopenia and neutropenia. Thiopurine-induced bone marrow suppression is dose-related and, although rare, can develop suddenly and unpredictably. Symptoms may not become apparent until the person is severely ill with sepsis. Fatalities from overwhelming infection associated with azathioprine or mercaptopurine have occurred. Most cases, however, recover within 1 month of drug withdrawal. Leukopenia is a myelotoxic side effect of thiopurines, and the metabolic phenotype of the patient can be defined by measuring thiopurine methyltransferase, abbreviated as TPMT, activity. Evidence that thiopurine methyltransferase activity predicts other side effects or outcome is limited, and only 1 in 300 people is severely deficient. It is not yet recommended as a prerequisite to therapy, but many gastroenterologists have introduced thiopurine methyltransferase testing into their practice, where they are considering commencing a thiopurine at the next clinic review. Pancytopenia and isolated thrombocytopenia may also occur with thiopurines. 2. Pancreatitis may occur in 3 to 15% of people taking a thiopurine. Pancreatitis appears to be an allergic reaction and often occurs within 3 to 4 weeks of starting therapy. Following discontinuation of the drug, the pancreatitis resolves and does not lead to the development of chronic pancreatitis. 3. A recent meta-analysis suggested that patients with inflammatory bowel disease who take azathioprine have a slightly increased risk of lymphoma, particularly B-cell lymphoma associated with Epstein-Barr virus infections. No increased risk has been shown for other cancers. The BSG recommends weekly FBC for the first 8 weeks of therapy, followed by blood tests at least every 3 months. It is important to advise anyone taking a thiopurine to report promptly should a sore throat or other sign of infection occur. Some clinicians will also monitor LFTs at the same frequency as hepatitis can occur, although the incidence is low, 0.3%. Patients who take thiopurines should avoid allopurinol, as it inhibits the breakdown of thiopurines and results in an increased risk of myelosuppression. Next we will discuss methotrexate in inflammatory bowel disease. It is unlicensed for use in inflammatory bowel disease, and patients should remain under specialist follow-up. Polyglutamate metabolites of methotrexate inhibit dihydrofolate reductase, but this cytotoxic effect does not explain its anti-inflammatory effect. Inhibition of cytokine and eicosanoid synthesis probably contribute. Methotrexate is effective for inducing and maintaining remission in Crohn's disease patients refractory to or intolerant of thiopurines. Trials on the use of methotrexate in ulcerative colitis are lacking. It can be administered orally or by intramuscular or subcutaneous injection. Oral administration is more convenient, but parenteral administration may be more effective. Doses of below 15 mg per week are ineffective in active Crohn's disease, unlike rheumatoid arthritis, and 25 mg per week is the standard induction dose. After 16 weeks, the dose is reduced to a maintenance dose of 15 mg per week. Studies have shown that patients can be maintained in remission on methotrexate for up to 8 years, and that patients whose methotrexate was discontinued tended to relapse after 6 to 12 months. Next we will discuss side effects and monitoring. Treatment is discontinued in 10 to 18% of patients because of side effects. Early toxicity from methotrexate is primarily gastrointestinal, such as nausea, vomiting, diarrhea, and stomatitis, and this may be limited by co-prescription of folic acid 5 mg 2 or 3 days apart from the methotrexate. Headache, dizziness and fatigue may also occur. The principal concerns are hepatotoxicity and pneumonitis. Factors which may predispose patients to liver toxicity from methotrexate include alcohol use, abnormal baseline LFTs, concomitant diabetes, obesity, or a cumulative dose of above 1.5 grams of methotrexate. Bone marrow suppression is less common with methotrexate than with thiopurines. Measurement of FBC and LFTs are advisable before therapy and weekly in the first 4 weeks, and then monthly. Next we will discuss cyclosporin in inflammatory bowel disease. Cyclosporin is an inhibitor of calcineurin, preventing clonal expansion of T-cell subsets. Intravenous cyclosporin is rapidly effective as a salvage or rescue therapy for patients with refractory ulcerative colitis who would otherwise face colectomy. Response rates may be as high as 80%, but its use is controversial because of toxicity and long-term failure rate, that is 50% of those who respond will still need surgery within a year of treatment. Cyclosporin is unlicensed for use in inflammatory bowel disease and patients should remain under specialist follow-up. Toxicity can be reduced by using lower doses, that is 2 mg per kilogram per day intravenously. It is usually given for 3 to 7 days, but may be followed in those who respond by oral cyclosporin as neoral, dosed at 5 mg per kilogram per day, for 3 to 6 months. Used in this way, it acts as a bridge to thiopurine therapy as this is introduced. A meta-analysis of 4 randomized controlled trials showed that cyclosporin has no therapeutic value in Crohn's disease. We will now discuss the side effects and monitoring. Measurement of blood pressure, FBC, renal function and cyclosporin levels are essential for monitoring both benefits and toxicity. Measurement of blood cholesterol and magnesium are appropriate before starting therapy. Minor side effects occur in 31 to 51% and include tremor, paresthesia, malaise, headache, abnormal liver function, gingival hyperplasia, and hirsutism. Major side effects include 1. Renal impairment. Creatinine clearance is reduced in most patients but usually returns to normal after drug cessation. Dose reduction or discontinuation of therapy is indicated if there is evidence of nephrotoxicity during treatment. Up to 20% of people treated with cyclosporin may have irreversible histological evidence of nephrotoxicity. 2. Infections. Immunosuppressive effects of cyclosporin result in a significant risk of infection. The risk is dose-dependent and compounded by co-treatment with corticosteroids. Infectious complications include opportunistic pathogens. 3. Neurotoxicity. Seizures have been reported, particularly in patients with a low cholesterol below 3 mmol per liter or low magnesium below 0.5 mmol per liter. Next we will discuss antibiotics in inflammatory bowel disease. Metronidazole, dosed at 10 to 20 mg per kilogram per day, has proved beneficial in the induction of remission of colonic Crohn's disease, but not ulcerative colitis. It is as useful as aminosalicylates for prevention of post-operative recurrence in Crohn's disease. Antibiotics, that is metronidazole and/or ciprofloxacin, are used for 3 months as first-line therapy in patients with severe perianal disease. They are effective for improving symptoms of the disease, but rarely induce complete healing. Exacerbation is the rule when antibiotics are withdrawn. Side effects of antibiotics are a concern. Short-term side effects of metronidazole tend to be dose-related and include metallic taste, gastrointestinal upset and abreaction to alcohol. The major long-term side effect is polyneuropathy. Ciprofloxacin is better tolerated in the short term, but is associated with tendinitis and Achilles tendon rupture, especially with concomitant steroids. Next we will discuss nutritional therapy in inflammatory bowel disease. The therapeutic efficacy of enteral feeds was first suspected in patients given pre-operative nutritional support. Both elemental, that is nitrogenous-free amino acids, and polymeric, containing whole protein and fat, diets have been studied in Crohn's disease and show no difference in efficacy. In a Cochrane systematic review, the 4 rigorously controlled trials comparing enteral therapy with prednisolone showed steroids to be more effective. Enteral therapy is regarded as appropriate for adjunctive treatment in Crohn's disease to support nutrition and not for primary therapy. It is generally considered appropriate to induce remission only for patients who decline other drug therapy, as steroids are preferred. In addition, up to 1/3 of patients are intolerant of these diets, nausea and putrid taste, which limits their usefulness. We will now discuss biological therapies in inflammatory bowel disease. Tumor necrosis factor alpha (TNF-alpha) is a pro-inflammatory cytokine produced by macrophages and lymphocytes and is found in large quantities in inflammatory diseases, including inflammatory bowel disease. The number of tumor necrosis factor-producing cells is greatly increased in the lamina propria in the bowel of people with Crohn's disease. Tumor necrosis factor is also found in large amounts in the mucosa of people with active ulcerative colitis. Tumor necrosis factor has multiple biological actions, including the mediation of inflammatory responses and modulation of the immune system. Anti-TNF agents became available in the late 1990s and have been developed to block the effects of TNF-alpha. Anti-TNF agents are high-cost drugs. Infliximab, marketed as Remicade, was the first anti-TNF to be licensed for use in people with severe active Crohn's disease or fistulizing active Crohn's disease, who have not responded to conventional therapy or who have experienced toxicity from these treatments. More recently, adalimumab, marketed as Humira, also a TNF-alpha inhibitor, has been licensed for use in similar groups of people with Crohn's disease. 2 further agents are in clinical trial in refractory Crohn's disease, certolizumab pegol, a TNF-alpha inhibitor, and natalizumab, a selective adhesive molecule inhibitor. Neither of these drugs is currently licensed for inflammatory bowel disease in the UK. Based on the favorable outcome of 2 studies published in 2005, ACT1 and ACT2, infliximab is also licensed for use in moderately to severely active ulcerative colitis in similar groups of people to Crohn's disease. Adalimumab is licensed for the treatment of severe ulcerative colitis in patients whose condition has not responded adequately to conventional therapy, or who are intolerant of it. It is also licensed for maintenance therapy in ulcerative colitis. However, in the absence of a submission from the manufacturer, adalimumab was not recommended by NICE for use in the treatment of moderate to severe ulcerative colitis 2012. Another agent, golimumab, has been licensed recently for the treatment of severe ulcerative colitis in patients whose condition has not responded adequately to conventional therapy, or who are intolerant of it. Golimumab is also licensed for maintenance therapy in ulcerative colitis. However, currently NICE do not recommend golimumab for the treatment of moderately to severely active ulcerative colitis. NICE is intending to complete a multiple technology appraisal of all three biological agents, such as infliximab, adalimumab and golimumab, in February 2015 for the treatment of moderately to severely active ulcerative colitis after the failure of conventional therapy. Next we will discuss adalimumab. Adalimumab is a recombinant fully human immunoglobulin monoclonal antibody that binds with high affinity and specificity to TNF. The Classic 1 study showed the efficacy of adalimumab in inducing remission in patients with moderately to severely active Crohn's disease who had not previously received anti-TNF therapy. The CHARM trial investigated the efficacy of adalimumab for maintenance of clinical response and remission in 854 patients. The clinical remission rate at weeks 26 and 56 was significantly greater for patients on adalimumab 40 mg every other week 40% and 36%, and 40 mg weekly 47% and 41% than in patients on placebo 17% and 12%. Adalimumab is indicated for treatment of severe active Crohn's disease, in patients who have not responded despite a full and adequate course of therapy with a corticosteroid and/or an immunosuppressant, or who are intolerant to or have medical contraindications for such therapies. For induction treatment, adalimumab should be given in combination with steroids. Adalimumab can be given as monotherapy in case of intolerance to steroids or when continued treatment with corticosteroids is inappropriate. Adalimumab is available as a pre-filled pen or pre-filled syringe and is given as a subcutaneous injection. After proper training in injection technique, patients may self-inject with adalimumab with medical follow-up as necessary. Next we will discuss infliximab. Infliximab is a chimeric human murine monoclonal antibody that binds with high affinity to TNF-alpha, inhibiting its activity. In people with Crohn's disease, infliximab has been shown to induce clinical remission in patients unresponsive to standard treatment, to clear anatomic damage and, when used as maintenance treatment, to maintain clinical remission, and fistula closure. Infliximab is licensed for the management of severe active Crohn's disease and moderate to severe ulcerative colitis in patients whose condition has not responded adequately to treatment with a corticosteroid and a conventional immunosuppressant or who are intolerant of them. Infliximab is also licensed for the management of refractory fistulizing Crohn's disease. Infliximab is a powder that requires reconstitution and dilution before administration as an infusion over at least 2 hours. It should be used by specialists where adequate resuscitation facilities are available. NICE guidance indicates that infliximab and adalimumab are recommended for the treatment of people with severe Crohn's disease who fulfill all three of the following criteria: 1. Those that have severe active Crohn's disease. 2. Those whose condition has proved to be refractory to treatment with immunomodulating drugs, that is azathioprine, mercaptopurine, and methotrexate. 3. Those people for whom surgery is inappropriate, e.g. because of diffuse disease and/or a risk of short bowel syndrome. As of 2012, NICE guidelines recommend that maintenance therapy for severe Crohn's disease with either infliximab or adalimumab may be continued under specialist supervision if there is clear evidence of ongoing active disease as determined by clinical symptoms, biological markers and investigation. Episodic treatment is recommended for those patients who match the above criteria and have responded to the initial treatment course, but then relapsed. Infliximab should be prescribed by a gastroenterologist who is experienced in the use of anti-TNF therapy and the management of inflammatory bowel disease. In ulcerative colitis, the findings of a recent Cochrane review are that infliximab is effective at inducing remission or clinical response in people with moderate to severe ulcerative colitis who are refractory to or intolerant of conventional treatment using corticosteroids and/or immunosuppressants. However, in April 2008, NICE issued guidance that infliximab is not recommended in ulcerative colitis for the treatment of subacute manifestations, disease that would normally be managed in an outpatient clinic and that does not require hospitalization or urgent surgery. In severe, acute ulcerative colitis requiring hospitalization, infliximab may be effective at helping to prevent colectomy in the short term. NICE recommend infliximab as an option for the treatment of acute exacerbations of severe ulcerative colitis when treatment with cyclosporin is contraindicated or clinically inappropriate. Next we will discuss the side effects of infliximab. Common adverse events following treatment with infliximab are nausea, headache, dizziness, rash, raised LFTs, abdominal pain, fatigue, dry skin and upper respiratory tract infections, particularly sinusitis. Other more serious complications include 1. Immunogenicity. Infliximab may be immunogenic, and episodic as well as continuous administration may result in the formation of antibodies against infliximab that can cause infusion reactions, loss of efficacy, and delayed hypersensitivity reactions. Infusion reactions during or shortly after infusion are common and respond to slowing the infusion rate or treatment with antihistamines, paracetamol, and sometimes steroids. Anaphylactic reactions have been reported. Patients retreated after a break need to be appropriately counseled because reactions can occur within 12 days of administration. 2. Another group of common complications are infections. 32% of patients require antimicrobial agents, but only 4% of infections are severe. Infliximab has been associated with invasive aspergillosis, histoplasmosis, cytomegalovirus, listeriosis, tuberculosis reactivation and pneumocystis jirovecii or Carinni pneumonia. 3. New-onset heart failure and exacerbation of existing heart failure have been associated with infliximab. 4. Rare post-marketing cases of hepatosplenic T-cell lymphoma have been reported in adolescent and young adult patients with Crohn's disease treated with infliximab. Next we will discuss topical therapy in inflammatory bowel disease. Topical drug delivery systems to the lower GI tract take the form of suppositories, liquid enemas or foam enemas. Each liquid or foam enema preparation has a different delivery system and rate of expulsion and expansion for the foam. Patient preference is therefore important. One preparation may be tolerated much better than another. In particular, patients can experience difficulty retaining liquid enemas. Delivery systems for foam enemas may cause the drug to bypass the rectum. A reflex rectal contraction also serves to move the medication beyond the rectum. After 4 hours, only 40% of foam enemas and 10% of liquid enemas is within the rectum, the majority being in the sigmoid colon. Rectal preparations should be administered at bedtime to facilitate retention for as long as possible. Enemas can be warmed and should be inserted while lying on the left side with the right knee bent. Next we will discuss concurrent therapy in inflammatory bowel disease. We will begin with antidiarrheals. Diarrhea is a distressing feature of inflammatory bowel disease, however, antidiarrheals do not reduce stool frequency in colitis. Care should be taken with opiate agents as they can diminish colonic motility and may lead to stasis and toxic megacolon. Cholestyramine may be useful in diarrhea associated with bile acid malabsorption. Bile salts have a cathartic effect on the colon, stimulating water and electrolyte secretion. A dose of 4 grams per day of cholestyramine is sufficient to bind bile salts, inhibiting this cathartic action. However, the dose should be titrated up to the maximum, 12 to 24 grams per day, to alleviate symptoms. Regarding pain management, abdominal pain is a common but under-researched feature of inflammatory bowel disease. Most analgesics are relatively ineffective and have the potential to worsen underlying disease. Pain relief usually follows treatment of the underlying inflammation, however, paracetamol or tramadol can be considered if needed. NSAIDs should be avoided as they are a well-recognized cause of exacerbation. Next we will discuss complementary medicine in inflammatory bowel disease. Surveys of the use of complementary medicine by people with GI complaints have reported rates of usage ranging from 9% to over 50%. As in other contexts, the single most used type for GI disorders is herbal therapy. Usage appears to be most common in people with inflammatory bowel disease and IBS. Reports in medical literature include the use of 1. Traditional Chinese medicine, 2. Aloe vera gel taken orally, 3. Wheatgrass juice, 4. Turmeric, 5. Frankincense, 6. Acupuncture, and 7. Bovine colostrum. Probiotics are products containing viable microorganisms that are non-pathogenic and confer health benefits beyond the nutritional value. Interest in probiotics in inflammatory bowel disease is currently high and there are many products to choose from in an unregulated market. Clear evidence for the efficacy of probiotics is lacking. However, a probiotic strain, Escherichia coli Nissl 1917, is now viewed as an effective alternative to aminosalicylates for maintenance of remission in ulcerative colitis. Prognosis. Next we will discuss mortality. Inflammatory bowel disease is a major cause of debilitation morbidity, particularly among young adults, rather than mortality where mortality rates are similar to those of the general population. Patients with inflammatory bowel disease have been shown to have impaired health-related quality of life (HRQOL) compared with healthy controls in physical, emotional, and social function. Overall, patients with ulcerative colitis have a normal life expectancy. Ulcerative colitis has a slight excess of mortality in the first 2 years after diagnosis, and a severe attack remains a life-threatening illness. After the first year, approximately 90% of patients are fully capable of work, defined by less than 1 month off work per year, although ulcerative colitis causes significant employment problems for a minority. The life expectancy of patients with Crohn's disease is slightly reduced. Mortality is greatest in the 2 years after diagnosis or in those with upper GI disease. Crohn's disease tends to cause greater disability than ulcerative colitis, with only 75% of patients fully capable of work in the year after diagnosis and 15% of patients unable to work after 5 to 10 years of disease. Next we will discuss the natural course of inflammatory bowel disease. Crohn's disease can change from non-stricturing to either stricturing in 27% or penetrating in 29% disease. Population-based data from Denmark showed that after the first year following diagnosis, 10 to 30% of patients with Crohn's disease have an exacerbation, 15 to 25% have low activity, and 55 to 56% are in remission. 13 to 20% of patients with Crohn's disease have a chronic active course of disease activity, 67 to 73% have a chronic intermittent course, and only 10 to 13% remain in remission for several years. After 20 years, most patients with Crohn's disease will require surgery. Half of patients with ulcerative colitis are in clinical remission at any given time, although 90% have an intermittent course. In the first 3 to 7 years following diagnosis, 25% of patients are in remission, 18% have activity every year, and 57% have intermittent relapses based on a cohort of patients from Copenhagen County. After 10 years, the colectomy rate in this cohort was 24%. Again, disease will change in ulcerative colitis, with more than half of patients with left-sided colitis progressing proximally, i.e. to the transverse and ascending colons, during 25 years. During the same period, patients with extensive colitis regress in about 75% of cases. Next we will discuss surgery. More than 80% of patients with Crohn's disease will undergo surgery during their life. It is estimated that the relapse rate is 10% per year. Thus, surgery tends to be palliative, and is not a definitive form of treatment. Patients who have had multiple and extensive surgical resections may have insufficient gastrointestinal tract remaining to absorb enough nutrients for the dietary requirement. This is known as short bowel syndrome, and these patients may require long-term parenteral nutrition, which, increasingly, is being provided at home. Surgery in ulcerative colitis is a curative measure, although some of the extra-intestinal complications may not resolve. Surgery has been refined to offer patients needing colectomy a better quality of life. Until the early 1980s, the gold standard for surgery was protococolectomy with an ileostomy. In the past 20 years, the new gold standard has become restorative proctocolectomy with ileal pouch-anal anastomosis, offering patients an unchanged body image with no stoma and a preserved anal route of defecation. Next we will discuss acute liver disease. As a way of introduction, the liver is the largest internal organ of the body and has a dual blood supply, shown in Figure 6. The hepatic portal vein delivers blood from the intestine to be processed before being returned to the general circulation, while the hepatic artery, which branches from the aorta, supplies the liver with oxygen. The individual functional units of the liver are called lobules. These are hexagonal arrangements of tissue formed around a central vein, that is the hepatic vein. A branch of the hepatic artery, a branch of the hepatic portal vein, and a bile duct are situated at each edge of these lobules. Blood from each lobule flows into large capillary spaces, that is sinusoids, which are connected to the central vein. The liver performs numerous essential functions that are listed in Table 9. Despite these numerous functions, there is little cellular specialization. Hepatocytes are the functioning units of the liver and perform a variety of metabolic and secretory roles. Phagocytic activities are carried out by Kupffer cells, and stellate cells are responsible for the fibrotic reaction that ultimately leads to cirrhosis. When the liver comes into contact with toxins or viruses, it undergoes inflammatory, that is hepatitis, or fatty, that is steatosis, changes, or both, that is steatohepatitis. These changes are usually reversible, the liver can regenerate, but damage can progress to fibrosis and cirrhosis, as shown in the definitions box. Pause the video and carefully scrutinize Table 9, which summarizes the main functions of the liver before advancing to the next slide. Next we will discuss liver dysfunction. A number of blood tests are used to assess liver function, but these cannot be used to quantify liver disease in the way that serum creatinine is used to assess kidney function. Liver function tests (LFTs) have previously been discussed in detail in Module PMY 7022. A full liver screen is required to help identify the cause of liver disease. This includes checking serum ferritin, copper, coagulation, and for viruses, autoantibodies, immunoglobulins, and alpha-fetoprotein, a tumor marker. Ultrasound is the first imaging study carried out where liver dysfunction is suspected. Liver biopsy may be required to establish a diagnosis, and determine treatment strategies, following histology, and prognosis. This is an invasive procedure, performed under local anesthetic, with inherent risks to the patient, most commonly bile leaks and bleeding. Pause the video and carefully scrutinize the table summarizing useful definitions before advancing to the next slide. Next we will discuss acute liver disease. Acute liver disease is defined as a self-limiting episode, not exceeding 6 months, of liver damage. Acute viral hepatitis and adverse drug reactions account for the majority of cases. Patients with acute hepatitis usually present with jaundice, and this can last for several weeks. Spontaneous recovery is the norm and there is no specific treatment. Next we will discuss viral hepatitis. Viral hepatitis is a common cause of both acute and chronic liver disease. Hepatitis A (HAV), hepatitis B (HBV), hepatitis C (HCV), hepatitis D (HDV), and hepatitis E (HEV) may all result in acute infection. Hepatitis A and HEV are discussed under acute liver disease, as these infections do not progress to chronic liver disease or to carrier status, unlike HBV, HCV and HDV, which can lead to persistent infection. Let's now discuss hepatitis A. Hepatitis A is an RNA virus, which is mainly transmitted enterically via the fecal-oral route. Hepatitis A is the most common type of viral hepatitis but is not very common in the UK, being more prevalent in countries with poor sanitary conditions. Vaccination against HAV may be recommended if patients are traveling to certain countries. After a relatively short incubation period of 2 to 7 weeks, the patient will present with jaundice and possibly hepatomegaly, splenomegaly and adenopathy. The majority of attacks are mild and often pass unnoticed by the patient. Adults can have more severe disease with large rises of transaminases and cholestasis, and rarely acute liver failure. Management: there are no effective antiviral agents against hepatitis A. Treatment is largely supportive, with jaundice resolving after a few weeks, and transaminases within a few months. Patients should be encouraged to rest, eat a normal diet and drink well and abstain from alcohol until their LFTs normalize. Next we will discuss hepatitis E. Hepatitis E is an RNA virus similar to hepatitis A, both in the mode of transmission and clinical presentation. It is very rare in the UK and is generally a mild and short-term infection. The main concern of hepatitis E infection is during pregnancy, where the maternal mortality rate is 20% and where miscarriage can occur at any stage. Regarding its management, treatment for hepatitis E is the same as for hepatitis A. Next we will discuss acute liver failure. Acute liver failure (ALF) is a serious clinical condition with a significant morbidity and mortality. It occurs when there is severe hepatic dysfunction associated with encephalopathy, coagulopathy and jaundice. The high mortality is a consequence of the marked disturbances in systemic circulation, analogous to septic shock, susceptibility to cerebral edema, renal failure and overwhelming sepsis, and also generalized derangements in metabolism such as hypoglycemia. Regarding its management, the clinical management consists of a combination of critical care medicine and liver transplantation, with pharmacists, specialist nurses, hepatologists, intensivists and transplant surgeons all having vital roles in the provision of care. Next we will discuss chronic liver disease. Chronic liver disease is marked by progressive, permanent structural changes within the liver, secondary to cell damage over time. The severity of chronic liver disease is usually assessed by using the Child-Pugh classification, which is based on 5 parameters: ascites, encephalopathy, serum albumin, serum bilirubin and INR. Generally, a decrease in albumin and/or an increase in INR indicate reduced synthetic function. Increased bilirubin may indicate reduced absorption and distribution of medicines. These parameters carry equal weighting towards the total score, with 15 being the highest attainable score, as shown in Table 10. The score is then converted into a designation of either Child-Pugh A, for practical purposes, with C representing the most advanced disease. Patients with Child-Pugh A are often referred to as having compensated disease, asymptomatic due to prescribed medicines or because there is enough healthy liver tissue to carry out normal functions, while the presence of overt clinical complications defines the presence of decompensated disease. Pause the video and carefully scrutinize Table 10 summarizing scoring for Child-Pugh classification of liver disease. The management strategy of any liver disease is a combination of treating the symptoms and complications that arise, and introducing medicines relevant to the specific underlying diagnosis. Some signs and symptoms of chronic liver disease are listed in Table 11. Pause the video and carefully scrutinize Table 11, which summarizes signs and symptoms of chronic liver disease before advancing to the next slide. Next we will discuss its complications. Pruritus, encephalopathy, ascites, variceal bleeding and hepatorenal syndrome are the main complications at which drug therapy is directed. Let's begin with pruritus. Pruritus, that is, itch, is a prominent symptom of chronic, particularly cholestatic, liver disease. The pathogenesis is poorly understood, but therapies that deplete bile acids, as well as centrally acting agents, are effective. In drug-induced cholestasis, the offending agent should be removed. Cholestyramine and colestipol are anion exchange resins, which are the usual first-line therapy. They act by binding bile acids and preventing their reabsorption. They are insoluble in water, non-absorbable, and are usually taken before meals to maximize the amount of bile acids sequestered. Cholestyramine is usually started at a dose of 4 grams once or twice daily and colestipol as 5 grams once or twice daily. The dose is titrated to give adequate relief without causing diarrhea, but palatability also restricts dosing. These drugs may reduce the absorption of drugs taken at the same time. To avoid this, drugs should be taken 1 hour before or 4 hours after cholestyramine or colestipol. Drugs that are particularly susceptible to the absorption-reducing effect of the anion exchange resins are levothyroxine, UDCA, digoxin, propranolol, hydrochlorothiazide, tetracycline and penicillins. Long-term therapy with anion exchange resins can also cause depletion of the fat-soluble vitamins. Rifampicin induces hepatic microsomal enzymes and has been shown to benefit some patients. The dose used should be 600 mg daily, and improvement begins between 1 and 3 weeks after commencement of therapy. Problems relate to hepatotoxicity and interaction with other drugs. Caution should be used in patients with pre-existing liver disease. It has been suggested that because central opioid receptors modulate itch, opioid antagonists might be useful in pruritus. Naloxone, naltrexone and nalmefene, unlicensed in UK, have consequently been shown to be effective. The disadvantage of naloxone therapy is that subcutaneous injection is required, in contrast to naltrexone and nalmefene, which are substantially more bioavailable after oral administration. Low starting doses should be used to prevent opioid withdrawal syndrome. Antihistamines are relatively ineffective, and sedating antihistamines may mask or precipitate encephalopathy. These sedative properties may, however, be useful at night if the severity of pruritus is keeping the patient awake. Ondansetron, a 5-HT3 antagonist, has been shown in non-comparative studies to be beneficial, removing itch 30 minutes after an 8 mg bolus intravenous injection, with improvement lasting for more than 24 hours. Although it has the advantage of being available as an oral preparation, variable results have been reported with this route of administration. Long-term use of ursodeoxycholic acid, abbreviated as UDCA, at 10 to 15 mg per kilogram per day in 2 divided doses, has been shown to improve pruritus, although it can occasionally worsen it. Thalidomide may decrease pruritus by its strong central depressant effect. Due to adverse effects, other treatments should be attempted first. Management of pruritus is variable. In desperate situations, as in cases of severe psychological problems associated with intractable pruritus, plasmapheresis, that is replacement of the plasma fraction of blood, albumin dialysis, molecular adsorbent recycling system, MARS, or transplantation may be needed. Next we will discuss encephalopathy. Hepatic encephalopathy is a reversible neuropsychiatric complication of cirrhosis. The pathogenic mechanisms are not fully understood and are thought to be multifactorial. It is thought that encephalopathy is a result of increased brain levels of toxins, such as ammonia, aromatic amino acids and gamma-aminobutyric acid, which accumulate because of poor hepatic function and portosystemic shunting. Clinical manifestations of encephalopathy range from slightly altered mental state to coma. Common precipitating factors include gastrointestinal bleeding, spontaneous bacterial peritonitis abbreviated as SBP, constipation, dehydration, hyperkalemia, sedative use, and a high oral protein load. Clinical prognosis after developing overt hepatic encephalopathy is poor, with 1-year survival estimated at 42% and 3-year survival estimated at 23%. However, most clinical manifestations of moderate disease are reversible with effective treatment. Therapeutic management is aimed at reducing the amount of circulating ammonia or nitrogenous products. Lactulose, a non-absorbable disaccharide, is routinely used to decrease ammonia production in the gut. It alters the handling of nitrogen within the intestine by decreasing transit time and promoting nitrogen fixation by bacteria in the colon, thus increasing the soluble nitrogen output in the feces. For acute encephalopathy, lactulose 45 ml should be followed by dosing every hour until evacuation occurs. Dosing is then adjusted to an objective of 2 to 3 soft bowel movements per day, generally 15 to 45 ml every 8 to 12 hours. Side effects include initial bloating and flatulence. More severe complications, such as persistent diarrhea, dehydration and acidosis can occur, therefore correct dose titration is essential. Antibiotics are used in the treatment of encephalopathy to reduce the mass of enteric bacteria that produce ammonia. Neomycin, which was the traditional treatment, has largely been abandoned because of the renal toxicity associated with chronic usage. Metronidazole is the preferred option, dosed at 200 mg twice daily, and rifaximin, unlicensed in the UK, 400 mg 3 times daily is being used more commonly due to favorable tolerability and safety profiles. Other therapies include L-ornithine L-aspartate, sodium benzoate, dopamine agonists, bromocriptine, and benzodiazepine receptor antagonists, like flumazenil. Of these, the most commonly seen in clinical practice is L-ornithine L-aspartate, HEPA-MERTS, unlicensed in the UK, which lowers serum ammonia levels by providing substrates for the intracellular metabolic conversion of ammonia to urea and glutamine. Results from controlled trials suggest that it provides therapeutic benefits in patients with chronic mild to moderate encephalopathy. Next we will discuss portal hypertension. Portal hypertension occurs when there is increased pressure within the hepatic portal vein, due to obstructed blood flow through the liver. Non-selective beta blockers, e.g. propranolol, may be used to lower portal blood pressure by reducing splanchnic blood flow. A transjugular intrahepatic portosystemic shunting, abbreviated as TIPS procedure, can also be performed to control portal hypertension through the creation of a shunt between the portal vein and the hepatic venous system. Next we will discuss esophageal varices. Variceal hemorrhage occurs from dilated veins, that is varices, at the junction between the portal and systemic venous systems. These tend to be in the distal esophagus or the proximal stomach. Variceal bleeding is a serious complication of portal hypertension and has a poor prognosis. In patients with suspected variceal bleeding, that is a history of previous variceal bleeding, signs of chronic liver disease or portal hypertension, endoscopy should be performed once appropriate resuscitation has been undertaken. This can include use of terlipressin as a vasoconstrictor to reduce portal pressure in patients with active bleeding with the aim of stopping or reducing immediate blood loss. Once variceal hemorrhage is confirmed, this is managed by ligation, that is banding. Banding uses pre-stretched rubber bands applied to the base of the vein, which has been sucked into the banding chamber attached to the front of an endoscope. Variceal band ligation controls bleeding in approximately 90% of cases, and is associated with fewer adverse effects than other management strategies. Following banding, patients should receive vasoactive drug treatment. Options include terlipressin 2 mg 4 times daily for 48 to 72 hours, or high-dose somatostatin or octreotide, which is a somatostatin analog, for 3 to 5 days. TIPS is highly effective in the management of uncontrolled variceal bleeding and is the intervention of choice when endoscopic measures have failed. Once acute bleeding is successfully controlled, the recurrence of variceal bleeding can be as high as 50% within the first day of the acute episode and 80% within 1 year. Due to the high risk of mortality, both primary and secondary prophylaxis must be considered. Non-selective beta blockers, such as propranolol, are the drug therapy of choice for primary prevention. They reduce portal pressure by decreasing splanchnic blood flow and the hyperdynamic circulation associated with cirrhosis. The starting dose is 40 mg twice daily and it is titrated to achieve optimum pulse rate and systemic blood pressure. For secondary prophylaxis, banding performed at regular intervals 1 to 2 weeks combined with a beta blocker is recommended. Once varices have been eradicated, endoscopic follow-up can be performed less frequently. In patients unsuitable for banding, a combination of non-selective beta blocker and a nitrate with synergistic effect is recommended for secondary prevention. Next we will discuss ascites and spontaneous bacterial peritonitis. The precise mechanism by which ascites, which is an abnormal collection of intra-abdominal fluid, develops in chronic liver disease is unclear, but portal hypertension, reduced osmotic pressure and activation of the renin-angiotensin-aldosterone axis as a consequence of vasodilation are contributory factors. Therapy should include reduction in sodium intake, that is a no-added salt diet of 90 millimoles or 5.2 grams salt per day, and diuretics. Consider the sodium content of effervescent tablets, IV fluids and IV medicines. IV antibiotics contain 2.1 to 3.6 millimoles of sodium per gram. There is no need to fluid restrict in uncomplicated ascites. Diuretic therapy is usually initiated with an aldosterone antagonist such as spironolactone, either alone or in combination with a loop diuretic. Typically, spironolactone is introduced at a dose of 100 mg daily, but it could be several days before a therapeutic effect is observed. The dose may be progressively increased every 3 to 5 days up to 400 mg. Furosemide 40 mg daily may be added if spironolactone fails to resolve the ascites. The dose is generally increased every 2 to 3 days up to a dose not exceeding 160 mg per day. The doses of diuretics are gradually increased to achieve a maximum daily weight loss of about 0.5 kg per day. More aggressive body weight reduction in the absence of peripheral edema is likely to lead to intravascular fluid depletion. British Society of Gastroenterology (BSG) guidelines recommend diuretic treatment according to sodium and creatinine levels as shown in Table 12. Pause the video and carefully scrutinize Table 12 summarizing BSG guidelines for diuretic therapy in ascites. Ascites is considered to be diuretic-resistant when intensive treatment with spironolactone 400 mg or furosemide 160 mg for at least a week and dietary sodium restriction does not work. Diuretic intractable ascites is that which is refractory to therapy due to the development of diuretic-induced complications that preclude the use of an effective diuretic dosage. 50% of patients with refractory ascites die within 6 months. Therapeutic paracentesis is the first-line treatment for patients with large or refractory ascites. Large volume paracentesis is generally required every 2 to 4 weeks, with volume expansion being given once the procedure is complete, preferably using 8 grams albumin per liter of ascites removed, that is 100 milliliters of 20% albumin per 3 liters of ascites. Failure to give this volume expansion can lead to post-paracentesis circulatory dysfunction with impairment of renal function and electrolyte disturbances. Tips can be used for the treatment of refractory ascites requiring frequent therapeutic paracentesis more than 3 times a month with appropriate assessment of risk-benefit ratio. Liver transplantation, if appropriate, is the definitive treatment option. Patients with ascites should be closely observed for spontaneous bacterial peritonitis, abbreviated as SBP. Spontaneous bacterial peritonitis is the development of a monomicrobial infection of ascites in the absence of a contiguous source of infection. The prevalence of spontaneous bacterial peritonitis in cirrhotic hospitalized patients with ascites ranges between 10% and 30%, and it is associated with a high mortality rate of 90% if untreated, which is reduced to 20% with early diagnosis and prompt treatment. Diagnostic paracentesis is mandatory in any patient with ascites who is showing signs of decompensation, pyrexia or abdominal pain. A neutrophil count greater than 250 cells per millimeter cubed in acidic fluid is indicative of infection. The causative organism is of enteric origin in approximately 3/4 of infections and of skin origin in the remaining 1/4. Cefotaxime, that is 2 grams twice daily for 5 days, has been the most extensively investigated antibiotic in patients with spontaneous bacterial peritonitis because it covers 95% of the flora isolated from acidic fluid and achieves high acidic fluid concentrations during therapy. Other agents have been shown to be effective, such as co-amoxiclav and ceftriaxone. Prophylaxis against SBP is recommended for patients with previous episodes of spontaneous bacterial peritonitis. In patients who have had one episode of spontaneous bacterial peritonitis, oral norfloxacin, dosed at 400 mg daily, or ciprofloxacin 500 mg daily reduces the probability of recurrence of spontaneous bacterial peritonitis from 68% to 20%. Next we will discuss hepatorenal syndrome. Hepatorenal syndrome, abbreviated as HRS, is a form of functional renal impairment that is diagnosed in patients who have severe liver disease in the absence of any other identifiable causes of renal failure, such as hypovolemia, sepsis, glomerulonephritis or drug nephrotoxicity. It is caused by intrarenal vasoconstriction in response to peripheral vasodilatation. The syndrome is classified clinically into 2 different types. Type 1 is characterized by an abrupt onset and rapid progression of renal dysfunction over a period of less than 2 weeks. In Type 2 hepatorenal syndrome there is a slower decline in renal function, often over months, and it is usually associated with refractory ascites. The development of hepatorenal syndrome is associated with high mortality and a mean survival of less than 2 weeks. Type 1. The International Ascites Club, abbreviated as IAC, criteria for the diagnosis of hepatorenal syndrome is 1. Presence of cirrhosis and ascites. 2. Serum creatinine above 1.5 mg per deciliter, that is 133 millimoles per liter. 3. No improvement of serum creatinine after 2 days with diuretic withdrawal and volume expansion with albumin. 4. Absence of shock. 5. No current or recent treatment with nephrotoxic drugs. 6. Absence of parenchymal kidney disease as indicated by proteinuria more than 500 mg per day, microhematuria and/or abnormal renal USS. One of the main pharmacological treatments of HRS is terlipressin, a vasopressin analog with a potent splanchnic vasoconstrictor action. Treatment is initiated with 0.5 to 1.0 mg every 4 to 6 hours. Treatment is effective in 40 to 50% of patients. The use of terlipressin has demonstrated a reversal in HRS, usually type 1, and improvement in mortality, especially when used in combination with 20% albumin therapy. Hemofiltration in type 1 HRS and liver transplantation may be considered if unresponsive to other treatments. Next we will discuss forms of chronic liver disease. We will begin with viral hepatitis. HBV, HCV and HDV can cause persistent infection with chronic hepatitis. Other viruses that may also cause hepatitis include Epstein-Barr virus, herpes simplex and zoster and cytomegalovirus. Regarding hepatitis B is a DNA virus that causes acute hepatitis and 5 to 10% of such patients become chronic carriers. It is estimated that more than 2 billion people worldwide have been exposed to the virus. Approximately 350 million people are chronic carriers of HBV, of whom 15 to 40% will develop serious liver complications such as chronic hepatitis, cirrhosis and hepatocellular carcinoma. HBV is present in saliva, urine, semen, vaginal fluids and plasma. It is transmitted by contact with infected body secretions, either parenterally, through transfusion of contaminated blood or blood products, intravenous drug misuses sharing contaminated needles, contaminated tattoo, body piercing, electrolysis or acupuncture needles, after sexual contact, during birth, via vertical transmission or breastfeeding. The symptoms of acute hepatitis B are similar to those of hepatitis A, but the illness has a longer incubation period of 3 to 6 months. Jaundice may be seen in 30 to 50% of adults, but it is estimated that approximately 2/3 of those infected are asymptomatic. Acute infection is usually self-limiting but may progress to fulminant hepatic necrosis, which can be fatal. Chronic HBV is defined as the presence of hepatitis B surface antigens abbreviated as HBsAg in the blood or serum for a period of more than 6 months and is associated with viremia and hepatic inflammation. The risk of chronic infection with HBV depends on the nature of the patient's immune response to the initial infection. This varies according to the age at which the infection is acquired. There are 2 forms of active chronic hepatitis B: hepatitis B E antigen HBeAg positive and HBeAg negative, and they have a different clinical course. In people with HBeAg positive chronic hepatitis, the aim is to obtain HBeAg seroconversion, development of detectable antibodies, to anti-HBe positivity. Both spontaneous rate is 8 to 12% per year, and treatment-induced seroconversion to this inactive carrier state are usually favorable outcomes associated with improved patient survival. However, increasing viremia and recurrent hepatitis after seroconversion, 5% of patients, indicate the emergence of the HBeAg negative strain of the virus. HBeAg-negative chronic hepatitis is usually due to a precore mutant strain that does not cause infected cells to secrete HBeAg. The prevalence of HBeAg-negative hepatitis varies geographically. It is more common in Asia and the Mediterranean region than in Northern Europe. The clinical course is characterized by low HBV DNA levels, which usually fluctuate and are mirrored by fluctuating ALT levels. These patients have a poor prognosis. Next we will discuss the management of hepatitis B. An effective hepatitis B vaccine has been available since the early 1980s, and is used in individuals at high risk of contracting hepatitis B. Immunization may take up to 6 months to confer adequate protection, and a booster should be given 5 years after the primary course of vaccines. Post-exposure prophylaxis with hepatitis B immunoglobulin is also available for use in newborn infants of HBsAg-positive mothers, and after percutaneous or mucosal exposure to HBsAg-positive blood in healthcare settings. Hepatitis B virus replication is key to liver injury and disease progression. The goal of treatment for chronic hepatitis B is to prevent cirrhosis, HCC, and liver failure. The main aims of treatment are thus to suppress the virus to achieve HBeAg seroconversion or undetectable HBV DNA levels, or both, stop or reduce hepatic necroinflammation, and prevent the development of hepatic decompensation. For chronic HBV infection, treatment with alpha interferons or antiviral therapy should be considered. 2 recombinant interferons and peginterferon alpha-2A are licensed for the treatment of chronic hepatitis B. The dose-related side effects of interferons, influenza-like symptoms, lethargy, nausea, depression, can mean that they are not suitable for long-term treatment. The use is often limited by a response rate of 30 to 40% and relapse is frequent. Treatment should be discontinued if no improvement occurs after 4 months. Interferons are contraindicated in decompensated liver disease. Entecavir is a nucleoside analog and tenofovir disoproxil is a nucleotide analog. Both act by inhibiting the viral DNA polymerase responsible for HBV replication and can be given either as a finite course of treatment or as long-term viral suppressive therapy. If there is no toxicity or loss in efficacy, treatment is usually continued until 6 months after adequate HBeAg seroconversion has occurred, usually about a year, or long-term in patients with decompensated liver disease. The National Institute for Health and Clinical Excellence (NICE) issued technology appraisals on peginterferon alpha-2A in 2006, entecavir in 2008 and tenofovir disoproxil in 2009. The recent NICE Clinical Guideline (CG 165), published in June 2013, recommends the following treatment strategies. Treatment sequence in adults with HBeAg-positive chronic hepatitis B and compensated liver disease. 1. Offer a 48-week course of peginterferon alpha-2A as first-line treatment in adults with HBeAg-positive chronic hepatitis B and compensated liver disease. 2. Offer tenofovir disoproxil as second-line treatment to people who do not undergo HBeAg seroconversion or who revert to being HBeAg positive following seroconversion after first-line treatment with peginterferon alpha-2A. And 3. Offer entecavir as an alternative second-line treatment to people who cannot tolerate tenofovir disoproxil or if it is contraindicated. Treatment sequence in adults with HBeAg-negative chronic hepatitis B and compensated liver disease. 1. Offer a 48-week course of peginterferon alpha-2A as first-line treatment in adults with HBeAg-negative chronic hepatitis B and compensated liver disease. 2. Offer entecavir or tenofovir disoproxil as second-line treatment to people with detectable HBV DNA after first-line treatment with peginterferon alpha-2A. At the time of publication of the NICE clinical guideline, entecavir and tenofovir disoproxil did not have UK marketing authorization for this indication. NICE recommends that prescribers should follow relevant professional guidance, taking full responsibility for the decision, and that informed consent should be obtained and documented. Peginterferon alpha-2A should be avoided in pregnancy unless the potential benefit outweighs the risk. Women of childbearing potential must use effective contraception throughout therapy with peginterferon alpha-2A. Next we will discuss hepatitis C. Hepatitis C is an RNA virus that rarely causes an acute hepatitis, but 85% of patients become chronic carriers. It is estimated that approximately 130 to 210 million people worldwide are chronically infected with HCV. There are 6 genotypes of this virus with different prevalences throughout the world. Genotypes 1 and 3 are the most common in the UK. The commonest route of infection in the UK is injecting drug misuse and the sharing of contaminated needles, as the virus is parenterally transmitted. Other lower risk factors include vertical transmission, less than 3%, tattooing, body piercing, electrolysis, acupuncture, and sexual transmission. Acute HCV infection is usually asymptomatic, leading to flu-like symptoms in some patients and clinical jaundice in less than 20%. Chronic infection is often silent, which probably leads to underestimation of its prevalence, but about 20% will develop overt hepatitis. Common routes to diagnosis are 1. Routine screening by the blood transfusion service. 2. Direct request for testing from the patient. And 3. Incidental discovery of abnormal liver function tests during investigation of unrelated symptoms. Chronic HCV infection is characterized by an immune-mediated hepatitis associated with progressive fibrosis. The liver stays inflamed, and about 20 to 30% of those infected will progress to significant liver fibrosis or cirrhosis within 20 years of infection. The likelihood increases in patients over 40 years old, men, and those who consume more than 6 units of alcohol per day. A small percentage of these people are at a high risk of developing hepatocellular carcinoma. Approximately a third of patients will have insignificant or minimal liver disease that may never progress to cirrhosis or will not progress for at least 50 years. HCV infection is the leading worldwide indication for liver transplantation.
Next we will discuss the management of hepatitis C. The aims of treatment are to eradicate HCV in the individual, prevent progression of liver disease and development of liver cancer, and to prevent transmission of HCV. Genotypes 2 and 3 respond best to treatment, whereas genotype 1 is the most difficult to treat. Treatment of chronic HCV involves a combination of peginterferon alpha, 2A, or 2B, and ribavirin. Peginterferon alpha may be used as monotherapy if ribavirin is not tolerated or contraindicated. The doses and duration of treatment depend on the brands used, the genotype affecting the patient, and the patient's weight for ribavirin dosing. The marker of response to the treatments is the sustained virological response, abbreviated as SVR, which is characterized by the virus being undetectable 6 months after treatment has finished. There is a risk of bone marrow suppression, and especially anemia, with ribavirin therapy. Patients should have their full blood count measured weekly for the first 4 weeks of treatment, then monthly. Opinion differs on the action to take if hemoglobin values fall. Reducing the ribavirin dose is an option but carries the risk of reduced efficacy. The use of recombinant human erythropoietin has been shown to be effective, unlicensed indication. Ribavirin is contraindicated during pregnancy and in women of childbearing age, and their male partners must use contraception during treatment and for 4 months after treatment has finished. Infected men and their female partners should each use effective contraception during treatment and for 7 months after treatment has finished.
Boceprevir and Telaprevir, non-structural 3-serine protease inhibitors, directly inhibit viral replication and may also restore the natural innate immune response of hepatocytes. UK Consensus Guidelines 2012 have concluded that either of these agents may be combined with peginterferon alpha and ribavirin in the treatment of genotype 1 chronic hepatitis C in adults with compensated liver disease in those who were previously untreated or in whom previous treatment has failed. Consideration must be given to drug interactions and side effects which include anemia, neutropenia, thrombocytopenia and rash and pruritus with tenofovir. Length of treatment for HCV genotype 2 or 3 is 24 weeks and 60 weeks in 1, 4, 5 or 6, but some patients who have a rapid virological response to treatment may be considered suitable for a shortened course of treatment. Next we will discuss hepatitis D. Hepatitis D is an incomplete RNA virus that can only replicate in the presence of HBV, and is acquired in the same way. Infection may occur at the same time as the hepatitis B infection, co-infection, or may be acquired at a later date, superinfection. The combination of hepatitis B with hepatitis D significantly increases the risk of both acute liver disease and cirrhosis. HDV should be suspected when a patient with chronic HBV infection develops signs of acute hepatitis. Infection can be prevented by immunizing against HBV. Next we will discuss alcoholic hepatitis. Alcohol intake is the most important cause of liver cirrhosis in the Western world. The Office for National Statistics data on alcohol-related deaths in the UK shows that 8,790 people died from alcohol in 2010, the latest year for which figures are available, and an increase of 126 from 2009. 4,144 deaths were recorded in 1991, thus more than twice as many people are dying from alcohol as 15 years ago. Alcohol-related deaths are higher in males and in those aged 55 to 74. Data on alcohol consumption from the General Household Survey, released January 2009, shows that over a third of adults exceed the recommended maximum alcohol guidelines on their heaviest drinking day. First described in 1961, alcoholic hepatitis, abbreviated as AH, is a syndrome of progressive inflammatory liver injury associated with chronic heavy intake of alcohol. At least 80% of heavy drinkers develop fatty liver, 10–35% develop alcohol hepatitis and about 10% will develop cirrhosis. Clinically, alcoholic hepatitis typically occurs in a heavy drinker, 40 to 70 units or more per week, over several years' duration. The Severity of Alcohol Dependence Questionnaire, abbreviated as SADQ, may be used to assess the presence and severity of alcohol dependence. Next we will discuss the pathogenesis of alcoholic hepatitis. In heavy drinkers, two mechanisms dispose of excess alcohol. 1. The majority of alcohol is oxidized normally in the liver or stomach by alcohol dehydrogenase to acetaldehyde. Acetaldehyde is then broken down into acetate, which is either converted further to carbon dioxide and water, utilized in the citric acid cycle, or acts as a precursor for the creation of fatty acids and fat. Acetaldehyde is thought to be the principal mediator of alcoholic liver injury and is held responsible for many of the features of alcoholic hepatitis. 2. Chronic alcohol consumption induces production of the enzyme cytochrome P450, which becomes the major pathway for alcohol metabolism in the chronic alcohol drinker. This is known as the microsomal ethanol oxidizing system. Microsomal oxidation of alcohol generates free radicals, resulting in mitochondrial injury and the initiation of an inflammatory response. Tumor necrosis factor alpha levels have been reported to be raised in alcoholic hepatitis, and the biological activities of this cytokine are altered, favoring inflammation and apoptosis rather than hepatocyte proliferation. Next we will discuss its diagnosis. Diagnosis of alcoholic hepatitis should be confirmed by clinical patient history, laboratory markers, ultrasound and biopsy. A common laboratory marker in detecting excessive alcohol consumption is a raised gamma-glutamyl transferase (GGT). Generally, serum transaminases, that is AST and ALT, are not greatly raised. Values greater than 5 times the upper limit of the normal reference range should lead to consideration of other diagnoses such as viral or autoimmune hepatitis. Hyperbilirubinemia reflects the severity of the hepatitis and is highly pronounced in alcoholic hepatitis. Prolongation of the prothrombin time and hypoalbuminemia reflect poor hepatocyte function. Regarding its prognosis, alcohol can cause significant liver damage without producing any symptoms or signs of liver disease, and often patients are diagnosed from routine liver function tests. Some heavy drinkers will present with acute alcoholic hepatitis, which, if severe, encephalopathy, renal failure, coagulopathy or jaundice, has a poor prognosis. In others, the first symptoms will be of cirrhosis or hepatocellular carcinoma because, up until presentation, the patient had compensated liver disease. The prognosis of alcoholic hepatitis is variable. Disease severity and mortality risks in patients with alcoholic hepatitis may be estimated by using Madri's discriminant function, abbreviated as DF, analysis, calculated as follows: discriminant function is equal to 4.6 multiplied by into brackets patient prothrombin time pages T minus control PT closed brackets plus serum bilirubin in micromoles per liter, all divided by 17.1. At 3 months after presentation, the mortality rate is 15% in patients with mild disease, that is a discriminant function below 24, 20% for moderate disease discriminant function 24 to 31, and 55% for severe disease discriminant function 32 or higher. Other scoring systems have been used, such as the Glasgow Alcoholic Hepatitis Score, abbreviated as GAHS, and the Model of End-Stage Liver Disease (MELD). Next we will discuss the management of AH. The mainstay of treatment is abstinence from alcohol and supportive care, although 18% of people will go on to develop cirrhosis despite abstinence. Treatment of alcohol withdrawal is generally initiated on admission, however the use of benzodiazepines in patients with incipient encephalopathy requires caution due to their sedative effects. Hypotension in AH requires careful monitoring of the patient's blood pressure and adequate fluid resuscitation. Malnutrition in AH has been shown to correlate closely with mortality. Nutritional support by mouth or by nasogastric tube, at least 25 kilocalories per day, should be started as soon as possible to support the metabolic functioning of the liver. Chronic alcohol consumption can result in thiamine deficiency by inadequate intake, decreased absorption or impaired cellular utilization. High doses of B vitamins should be given intravenously at first for at least 5 days unless Wernicke's encephalopathy is excluded, followed by oral thiamine to prevent Wernicke-Korsakoff syndrome, an acute neuropsychiatric disorder. This can further develop into Korsakoff's psychosis, which results in memory deficits, confusion and behavioral changes. Close vigilance for sepsis and a low threshold for the use of antibiotics is also required. Next we will discuss corticosteroids. Corticosteroids are used for their anti-inflammatory and immunosuppressant properties. Studies have produced conflicting results. Some meta-analyses have shown a beneficial role in alcoholic hepatitis, whereas others have questioned their efficacy. Overall, the available evidence supports the use of steroids in carefully selected alcoholic hepatitis patients with a DF above 32 and/or encephalopathy. Treatment is with prednisolone 40 mg daily for 4 weeks, followed by a gradual reduction to 0. Contraindications to corticosteroid therapy include uncontrolled infection, uncontrolled variceal bleeding, and renal failure. A fall in bilirubin at day 7 of corticosteroid treatment is highly predictive of survival. If bilirubin rises or remains static after this time, corticosteroids should be stopped. Next we will discuss pentoxifylline. Pentoxifylline is a TNF-alpha inhibitor. In one study, 101 patients with severe R were randomized to receive either pentoxifylline 400 mg 3 times daily or placebo for 4 weeks. Pentoxifylline was associated with improved short-term survival. The benefit appears to be related to the decreased risk of developing HRS. Further studies are needed to validate its use. Next we will discuss non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Rapidly increasing in prevalence, up to 30% of the population, in the United States, Western Europe and parts of Asia, non-alcoholic fatty liver disease, abbreviated as NAFLD, is a spectrum of liver diseases ranging from isolated fatty liver, steatosis, to non-alcoholic steatohepatitis, abbreviated as NASH. Although isolated fatty liver is thought to have a generally benign histopathological course, recent data suggest a link with increased risk of cardiovascular disease. It also appears that NASH may progress to cirrhosis at a rate of about 10% over 20 years. Next we will discuss pathogenesis. NAFLD is thought to occur in 2 hits, firstly the development of steatosis as a result of insulin and possibly leptin resistance, leading to the accumulation of triglycerides within the hepatocytes. Progression to steatohepatitis (NASH) is the second hit, where the excess fat causes inflammation. This involves oxidative stress that promotes lipid peroxidation and production of pro-inflammatory cytokines, leading to subsequent inflammation and fibrosis. More obese, older and diabetic patients are at greatest risk of developing cirrhosis. NAFLD can be caused by nutritional and endocrine disorders and also be drug-induced. It represents the hepatic manifestation of the metabolic syndrome and is related to obesity, insulin resistance, observed in up to 98% of patients with NAFLD, type 2 diabetes, hypertension and hyperlipidemia. Next we will discuss its management. Many patients are asymptomatic and the disease is only discovered when abnormal LFTs are detected during routine tests. Some patients will report malaise or a feeling of fullness in the right upper quadrant. Hepatomegaly may be present. There is no established pharmacological therapy for NAFLD or NASH. Dietary intervention and exercise, though lacking appeal and often limited by patient compliance, remain first-line therapy for this disease. Diet-induced weight loss is associated with physiologic changes that result in improved insulin sensitivity, reduced adipose tissue inflammation and reduced hepatic free fatty acid supply. As lifestyle changes are difficult to sustain long-term, pharmacotherapeutic or surgical approaches have been investigated in the treatment of NASH. Using the two-hit hypothesis, various targets for potential pharmacotherapy have been identified. These include therapies directed at improving insulin resistance, reducing oxidative stress, decreasing hepatic fibrosis, improving the underlying metabolic syndrome, or promoting weight loss. Surgical approaches also directed at weight loss have been investigated. A summary of insulin resistance treatment targets in NASH is illustrated in Figure 7. Pause the video and carefully scrutinize Figure 7 summarizing insulin resistance and treatment targets in NASH before advancing to the next slide. Next we will discuss metformin. Metformin in the treatment of NAFLD has produced mixed and generally disappointing results. In one study, 110 non-diabetic patients with NAFLD were treated over a 12-month period, 55 were treated with metformin 2000 mg daily, 28 with vitamin E, and 27 with a prescribed diet. Serum transaminases improved in association with weight loss in all groups, with metformin-treated patients showing the most biochemical improvement in multivariate analysis. Post-treatment liver biopsy performed on 17 of the metformin-treated group showed statistically significant changes in liver fat, necroinflammation and fibrosis. Although this was promising, any positive findings were tempered by the incomplete histologic follow-up of patients. A more recent Turkish study of 36 biopsy-proven NASH patients treated with metformin 850 mg twice per day plus a calorie-restricted diet versus diet alone for 6 months showed no significant differences in necroinflammatory activity or fibrosis between the two groups on repeat biopsy. Based on the currently available data, it seems reasonable to conclude that metformin is not an ideal monotherapy agent for the treatment of NASH. Next, let's discuss thiazolidinediones. The thiazolidinediones, abbreviated as TZDs, are another class of diabetic medications that have been extensively studied in the treatment of NASH. These medications include pioglitazone and rosiglitazone. A number of small studies have shown that TZDs improve histological data in patients with NAFLD. However, the side effects of TZDs, such as significant weight gain, may substantially limit the widespread use of these medications. Next, we will discuss immune disorders. Autoimmune disease can affect the hepatocyte or bile duct and is characterized by the presence of autoantibodies and raised immunoglobulin levels. Regarding autoimmune hepatitis, abbreviated as AIH, is associated with 1. Hyperglobulinemia, 2. Autoantibodies in the serum, and 3. A history of other autoimmune disorders. It typically occurs in young women, but it may develop at any age in either sex. It generally presents insidiously with anorexia, malaise, nausea and fatigue. Physical examination may reveal few clinical signs of chronic liver disease, but most patients have palmarerythema and spider nevi. Mild to moderate elevations of serum transaminases are usually observed. A minority of patients may present with severe, acute, uncontrollable hepatitis for which the only treatment is liver transplantation. The etiology and pathogenesis of AIH are unknown. Diagnosis is based on liver histology, serum biochemistry, and the detection of anti-nuclear antibodies, anti-smooth muscle antibodies and high titers of immunoglobulins. Approximately 20% of patients will have another form of autoimmune disease, such as rheumatoid arthritis. Next, we will discuss its management. The mainstay of treatment is immunosuppression with corticosteroids, with or without azathioprine. Treatment is aimed at inducing remission as early as possible and then to prevent relapse, as each relapse and associated liver damage is believed to hasten the progression to cirrhosis or exacerbate existing cirrhosis. Corticosteroid treatment is usually given as prednisolone 30 mg daily initially. This dose is then reduced gradually to 10 mg per day over 2 to 3 months. Azathioprine 1 mg per kilogram per day is often started a few weeks after the prednisolone. Patients should be asked about and/or tested for immunity to hepatitis A and hepatitis B infection, and susceptible patients offered vaccination as soon as possible. Patients should have baseline and weekly LFTs, blood sugar and FBC for 4 weeks, then 1 to 3 monthly thereafter depending on response. All should receive calcium and vitamin D supplementation, and DEXA bone density scans may be performed. Patients should be referred for glaucoma and cataract screening after 12 months prednisolone treatment. In 80 to 90% of patients with moderate to severe AIH, serum ALT falls after starting treatment, usually commencing within 2 weeks. As transaminases fall, clinical symptoms resolve. In 5 to 10% of patients, liver tests do not improve. Within 12 months of stopping treatment following remission, 50 to 90% of patients have a disease relapse. Patients who are intolerant of azathioprine or who do not respond to combined prednisolone and azathioprine should be switched to mycophenolate and prednisolone or double prednisolone dose. Next we will discuss primary biliary cirrhosis. Primary biliary cirrhosis, abbreviated as PBC, is an autoimmune, chronic cholestatic disease of the liver which predominantly affects middle-aged women. In the UK, the prevalence is up to 240 per million population and the incidence is 4 to 30 per million per year. Most cases, 60%, are diagnosed when asymptomatic with abnormal LFTs and/or the presence of antimitochondrial antibodies. When symptomatic, patients often present with fatigue, pruritus, and/or jaundice. Findings on examination can include hepatosplenomegaly and hyperpigmentation. Jaundice is a late presentation. Primary biliary cirrhosis may be associated with other autoimmune conditions, as well as some unique complications of cholestasis, such as fat-soluble vitamin deficiency, osteoporosis and hypercholesterolemia. The cholestasis associated with primary biliary cirrhosis is generally slowly progressive until cirrhosis and liver failure occur. The median survival is approximately 10 years without transplantation. Next we will discuss pathogenesis. Primary biliary cirrhosis appears to be a classic autoimmune disease in which a variety of environmental toxins or infectious agents, including viruses, bacteria, and chemicals, may trigger an immune response that becomes self-perpetuating. Genetic susceptibility is suggested by the increased frequency of primary biliary cirrhosis among first-degree relatives of index patients and by the association with certain HLA haplotypes. The eventual outcome of the immune reaction is the destruction of small intralobular bile ducts with resultant cholestasis, necroinflammation and fibrosis. Retained bile acids may cause damage to hepatocytes and increased expression of HLA antigens on hepatocytes, thereby enhancing the autoimmune response. Next we will discuss management. There is no cure but medication may slow disease progression. Liver transplantation is the treatment of choice for end-stage disease and the best results are obtained when it is performed before the serum bilirubin exceeds 150 to 170 micromoles per liter. Ursodeoxycholic acid, abbreviated as UDCA, is the only drug specifically licensed for PBC. It increases the rate of transport of intracellular bile acids into the canaliculus. The once-daily or divided dose of 10 to 15 mg per kilogram per day gives a marked improvement in LFTs and rarely there is improvement in symptoms. Reduction in serum alkaline phosphatase within 6 months of the introduction of therapy is a useful predictor of clinical response. UDCA is usually well tolerated, diarrhea is the only common side effect. At least a dozen studies have compared UDCA for the treatment of PBC with placebo. Although a recent meta-analysis of these trials did not suggest a beneficial effect of treatment with UDCA on rates of death or liver transplantation, some of the studies used what are now considered to be inadequate doses of UDCA or too short a period of follow-up. Other agents, including colchicine, methotrexate, penicillamine, azathioprine and cyclosporin, have been tested for the treatment of PBC but appear to lack beneficial effects similar to those of UDCA. There is currently no consensus on how to treat patients with a suboptimal biochemical response to UDCA. One suggested approach is the combination of UDCA and budesonide, 6 to 9 mg per day, in non-cirrhotic patients. Next we will discuss primary sclerosing cholangitis. Primary sclerosing cholangitis, abbreviated as PSC, is a chronic, cholestatic liver disease of uncertain etiology. It is characterized by progressive destruction of the intrahepatic and/or extrahepatic bile ducts through chronic inflammation and fibrosis, leading to biliary complications including bile stasis, cirrhosis and ultimately liver transplantation or death by 7 to 12 years after diagnosis. Cholangiocarcinoma occurs in approximately 10 to 30% of patients. Primary sclerosing cholangitis occurs more frequently in Caucasian men between the ages of 20 and 40. Often there is an association with chronic ulcerative colitis. Patients commonly have abnormal LFTs or symptoms such as fatigue, pruritus, pain and episodes of fever and chills. The diagnosis is then confirmed by imaging studies that show diffuse beading of the bile ducts in large duct primary sclerosing cholangitis, or by histology and biochemistry that reveal typical features of primary sclerosing cholangitis with a normal cholangiogram in small duct primary sclerosing cholangitis. Next we will discuss the management of primary sclerosing cholangitis. Treatment of primary sclerosing cholangitis has been attempted with immunosuppressants, anti-inflammatory agents, antifibrotic agents and bile acids. At present, liver transplantation is the only life-extending therapeutic option for patients with end-stage primary sclerosing cholangitis. Extrahepatic biliary strictures may be amenable to endoscopic dilation. UDCA is widely used at a dose of 10 to 15 mg per kilogram per day. It has consistently improved LFTs in several controlled trials, but none of these studies showed an improvement in the natural history of the disease. As with PBC, patients with primary sclerosing cholangitis are at risk of fat-soluble vitamin deficiency and osteoporosis. Supplementation should be given as needed and bisphosphonate therapy may also be considered. Next we will discuss vascular abnormalities. The main vascular abnormalities affecting the hepatic veins are the Budd-Chiari syndrome and veno-occlusive disease. Budd-Chiari syndrome is an uncommon condition induced by obstruction in the large hepatic veins, as a result of either a sudden thrombotic event or a slow fibrous occlusion, often due to an underlying disorder of coagulation. Hepatomegaly, ascites, and abdominal pain characterize Budd-Chiari syndrome. Medical therapy can be instituted for short-term, symptomatic benefit but alone is associated with a high 2-year mortality rate 80 to 85%. When symptoms begin suddenly and the cause is a clot, thrombolytic drugs have been used in a few cases. Agents include streptokinase, urokinase and tissue plasminogen activator. Longer-term, anticoagulant drugs are used to prevent clots from enlarging or recurring. If a vein is narrowed or blocked by a membranous web, angioplasty may be done to widen it. Another option is to create an alternate route for blood flow using tips, which reduces pressure in the portal vein. Liver transplantation is necessary if decompensated liver cirrhosis is present. Veno-occlusive disease, abbreviated as VOD, differs from Budd-Chiari syndrome in that it consists of occlusive fibrosis of the small intrahepatic veins. One of the main causes of VOD is the use of cyclophosphamide or alkylating agents during conditioning for bone marrow transplantation, where it occurs in up to 20% of cases. Next we will discuss metabolic or hereditary disorders. There are various inherited metabolic disorders that can affect the functioning of the liver. Hemochromatosis and Wilson's disease are outlined below, and others include alpha-1 antitrypsin deficiency, glycogen storage diseases, cystic fibrosis and Gilbert's syndrome. Hemochromatosis. Hereditary hemochromatosis, abbreviated as HH, is the most common identified genetic disease in Northern Europe. It is inherited in an autosomal recessive manner, presenting mostly in middle-aged men, and is usually due to mutations in the HFE gene located on chromosome 6. The disease results from excessive absorption of dietary iron which is subsequently deposited in tissues such as the pancreas, heart and liver. Many individuals with this condition will have no symptoms and liver function will not be affected. However, iron stored in the liver can cause hepatocyte damage that may progress from hepatitis to liver cirrhosis and end-stage liver disease. Next we will discuss management. Early diagnosis and preemptive treatment with venesection is required. Venesection is similar to the procedure used for donating blood and involves the removal of 1 unit, about half a liter, of blood at a time. At first, venesection should be performed weekly. The patient's FBC and LFTs should be monitored weekly and serum iron, total iron binding capacity and serum ferritin should be checked monthly. Frequent venesection stops when the hemoglobin reached 10 grams per deciliter. As venesection is a lifelong necessity, a maintenance schedule is required and this varies among individuals. Some patients require phlebotomy every month, whereas others will only need 3 to 4 units of blood removed per year. In symptomatic patients, certain clinical features are helped by venesection: malaise, fatigue, skin pigmentation, insulin requirements in diabetes, abdominal pain, whereas other features are either less responsive to iron removal or do not respond at all: arthropathy, cirrhosis. Chelation with desferrioxamine may be tried in rare patients who cannot tolerate venesection because of cardiac failure or anemia. Next we will discuss Wilson's disease. Wilson's disease is an autosomal recessive disorder of copper metabolism. The retention of copper begins at birth, but it may take decades before the liver is sufficiently damaged for symptoms of liver disease to occur. It can present as chronic hepatitis, asymptomatic cirrhosis or acute liver failure, or as neuropsychiatric symptoms and cognitive impairment. Regarding the management of Wilson's disease, copper chelation is an effective therapy in most patients and liver transplantation is curative in individuals presenting with irreversible liver failure. Penicillamine is the agent of choice in systemic chelation therapy. It promotes urinary copper excretion in affected patients and prevents copper accumulation in presymptomatic individuals. The initial treatment dose of 1.5 to 2 grams daily is given in divided doses. Most patients will be asymptomatic within 4 months, but neurological symptoms may worsen initially due to deposition of mobilized copper in the basal ganglia. Other potentially serious adverse events include renal dysfunction, hematological abnormalities and disseminated lupus erythematosus. As a result, regular FBC and electrolytes analysis are required, along with small doses of pyridoxine 25 mg to counteract the antipyridoxine effect of penicillamine. Triethylene tetramine dihydrochloride trientine is an alternative chelating agent. It is usually given at a dose of 1.2 to 2.4 grams daily in 2 to 4 divided doses before food. Although somewhat less effective than penicillamine in removing copper, significant improvement has been reported in many patients. Zinc acetate is also useful and is relatively free from adverse effects, but works solely and has been used primarily in maintenance therapy. In addition to chelation therapy, zinc salts can also be added to the therapeutic regimen to prevent copper absorption. Next we will discuss biliary tract disorders. Disruption of bile outflow from the liver can cause inflammation, scarring and eventual cirrhosis. Obstruction of bile flow may be due to cholelithiasis, that is gallstones, cholangiocarcinoma, that is tumor in the biliary tree, cysts, or as a result of damage to the biliary tree in conditions such as PBC or cholangitis, that is inflammation of the bile duct. It may also occur secondary to surgical or traumatic damage to the common bile duct. In children, congenital malformations resulting in biliary atresia or choledical cysts are causes of chronic liver disease. Next we will discuss drug-induced liver disease. Drugs that damage the liver account for 9.5% of all suspected adverse drug reactions (ADRs), are the main cause of fatal ADRs and are the most common reason for withdrawal of drugs from the market. Pre-market surveillance detects common ADRs, but those seen in clinical practice are rare, 1 over 10,000 to 100,000 prescriptions. The description depends on post-market surveillance via the yellow card scheme, but only 50% of liver-related ADRs are confirmed on review. Any type of liver injury can be reproduced by drugs, and any drug can produce different types of liver injury. For example, phenytoin can cause necrosis and cholestatic jaundice, and ibuprofen can produce microvesicular steatosis and hepatitis. Next we will discuss mechanism of liver injury. Drugs or one of their metabolites may have a direct effect, intrinsic hepatotoxicity, or, more commonly, may induce an immune reaction, that is idiosyncratic hepatotoxicity, possibly due to genetic disposition or idiosyncratic metabolism. Direct effects lead to predictable, dose-dependent toxicity, have a short latency period, that is hours to weeks, and are relatively infrequent. Immune reactions are less predictable, dose-independent, have a variable latency period, that is 5 to 90 days, and may be associated with hypersensitivity phenomena such as fever, rash and eosinophilia. Multiple factors interact in both intrinsic and idiosyncratic hepatotoxicity. See examples in Table 13. Pause the video and carefully scrutinize Table 13 summarizing factors affecting susceptibility to drug-induced liver disease before advancing to the next slide. Next we will discuss its diagnosis. Diagnosis of drug-induced liver disease depends on the medication history, that is the dose, route and duration of all drugs, including herbal and other purchased medicines, in the past 3 months, clinical history, to exclude other causes, and the results of investigations. Abnormalities are commonly detected 5 to 90 days after drug administration, but can occur up to 5 weeks post-withdrawal. Reaction on re-challenge may be immediate. Recovery, defined as above 50% decrease in abnormal LFTs on withdrawal of the suspected drug, supports the diagnosis, but the speed of recovery depends on the type of injury. Acute hepatocellular injury may take up to 2 months, cholestatic injury may take up to 6 months, and may worsen up to 2 weeks post-withdrawal or, rarely, is irreversible. Re-challenge reactions give a positive diagnosis but are not usually required and can be dangerous in acute-type hepatocellular reactions accompanied by features of hypersensitivity. Next we will discuss its management. Prevention, early recognition and prompt withdrawal of likely offending drugs are the most important elements. Specific antidotes are only available for paracetamol and iron. Sometimes, withdrawal does not prevent progression. Non-essential drugs should be withdrawn if LFTs become elevated above the normal range. Essential drugs may be reintroduced cautiously, depending on the known natural history of the ADR. There is limited evidence for the use of corticosteroids or UDCA. Management is generally supportive until recovery, but if liver failure ensues, transplantation is required. Next we will discuss drug use in liver disease. Patients with liver disease often require drug treatment, either for their liver disease and its complications, or for other comorbidities. There is no evidence that patients with liver disease are at increased risk of further liver damage when administered drugs known to cause idiosyncratic hepatotoxicity. There are a few exceptions where greater care is required, including hepatotoxicity with methotrexate, some chemotherapy agents and sodium valproate. In view of the reduced hepatic reserve in patients with pre-existing liver disease, liver damage induced by any drug may have more severe clinical consequences. The liver is the main site of drug metabolism, where pharmacologically active chemicals are converted into inactive hydrophilic metabolites, which can then be excreted by the kidneys. Hepatic metabolism is most important for lipid-soluble drugs, whereas hydrophilic drugs undergo predominantly renal excretion. Drug metabolism is normally divided into two phases. 1. Phase 1 pathways are metabolic reactions catalyzed by the cytochrome P450 enzymes located in the endoplasmic reticulum. 2. Phase 2 reactions are performed by various enzymes including the glucuronal transferases, sulfotransferases, N-acetyltransferases and glutathione S transferases, which are located in both the endoplasmic reticulum and the cytosol. Next we will discuss the effect of liver disease on drug pharmacokinetics. Changes in liver function can affect the body's response to drugs due to both pharmacokinetic and pharmacodynamic changes. Liver disease can affect drug pharmacokinetics through various mechanisms. These changes can be complex and sometimes unpredictable. Absorption gut motility is altered in patients with cirrhosis, probably as a result of abnormal levels of gut hormones such as motilin. The net result is a delay in gastric emptying and orocaecal transit, resulting in a reduction in the rate but not the extent of absorption. Is the drug lipophilic? Reduced bioavailability of lipophilic drugs may occur in cholestasis. Regarding distribution, we should ask ourselves: 1. Is the drug highly protein-bound? Chronic liver disease is characterized by hypoproteinemia, which may affect protein binding of drugs that are highly bound. However, this is of little clinical importance in view of the high capacity of the liver to metabolize drugs, unless the patient has severe liver impairment. Other changes include elevation of plasma volume and ascites, leading to an increase in the volumes of distribution of water-soluble drugs, such as aminoglycosides. Misinterpretation of total drug concentration measurements can occur if albumin below 30 grams per liter and the drug is above 80% bound to albumin. 2. Is the drug displaced by or does it displace bilirubin? In severe liver impairment, hypoalbuminemia and raised bilirubin may increase the free concentrations of some medicines, e.g. phenytoin, increasing the distribution. Drugs displaced by bilirubin may be affected by high bilirubin levels above 100 micromoles per liter. Regarding metabolism, hepatic impairment reduces the clearance of drugs metabolized by the liver. For those with a narrow therapeutic index, e.g. phenytoin, theophylline, there is a disproportionate increase in drug levels and hence toxicity, and a reduction in dose is therefore necessary. Such patients should be started on a low dose. Further dose changes are dictated by both the therapeutic response and adverse effects and therapeutic drug monitoring, when available. 1. Is the drug metabolized by the liver? Reduced hepatic metabolism is likely to be most significant in decompensated cirrhosis and acute liver failure. 2. Does the drug undergo high first-pass metabolism, i.e. does it have a high extraction ratio (ER)? If the drug undergoes substantial first-pass metabolism, this can result in a greater proportion of absorbed oral drug entering the systemic system, causing a large rise in bioavailability and the potential for increased adverse and therapeutic effects. 3. Liver blood flow is a major pharmacokinetic determinant. Blood flow to the liver may be decreased generally or may bypass the liver as a result of portosystemic shunting in patients with cirrhosis. In general, the higher the extraction by the liver, the more important is blood flow in determining pharmacokinetics by reducing first-pass metabolism. First-pass metabolism is also affected by portocaval shunts. Drugs, such as ergotamine, normally undergo first-pass metabolism bypass the liver, resulting in higher systemic bioavailability and severe toxicity. A reduction in dose of oral, but not parenteral, formulations may be required. 4. Patients with impaired metabolic capacity may require reduced maintenance doses of hepatically metabolized drugs. 5. Is the drug a prodrug requiring activation in the liver? Poor liver metabolism may reduce the rate or extent of activation and reduce the therapeutic effect of these drugs. Regarding excretion, 1. Renal elimination of hydrophilic drugs, or hydrophilic metabolites, is affected in patients with severe and rapidly advancing hepatic disease who develop HRS. Even moderate hepatic impairment can reduce renal clearance, necessitating a reduction in the dose of renally eliminated drugs. Serum creatinine is an insensitive marker of glomerular filtration rate in patients with cirrhosis because of the reduced muscle mass and reduced conversion of creatine to creatinine in the liver. 2. Does the drug undergo biliary excretion? In cholestatic patients, elimination via the biliary route may be reduced, resulting in accumulation. 3. Does the drug undergo enterohepatic recirculation? The drug may be excreted more slowly than usual in cholestasis. The effect of liver disease on drug pharmacodynamics. Drug response in liver disease is also determined by pharmacodynamic changes. These can result in increased or decreased sensitivity, or an increased risk of toxicity, figure 8, through changes in the function of other organs such as the brain and kidneys. Pause the video and carefully scrutinize Figure 8 before advancing to the next slide. Specific examples and mechanisms are shown in Table 14. Non-steroidal anti-inflammatory drugs (NSAIDs) enhance sodium and water retention and worsen ascites, and the effects on platelets, combined with clotting defects, increase the risk of bleeding. Bleeding into the gastrointestinal tract may also precipitate encephalopathy. Because of the changes in renal function in liver disease, NSAIDs affect intrarenal prostaglandins, and in some patients precipitate renal failure. Pause the video and carefully scrutinize Table 14 summarizing drugs that should be avoided or dose reduced in liver disease before advancing to the next slide. Next we will discuss the general rules for drug use in liver disease. Patients must be assessed carefully before prescribing any drug, to determine the risks and benefits. Several factors must be considered. 1. How serious is the condition that needs to be treated and what are the consequences of withholding treatment? 2. What drug treatments are available? 3. Are the efficacies of the different treatments equivalent? 4. When several drugs are available to treat the same condition, the drug with the largest therapeutic index should be chosen. 5. Will the drug be affected by any of the pharmacokinetic changes seen in patients with liver disease? 6. Will the drug worsen the pharmacodynamic changes seen in liver disease? 7. Is the drug potentially hepatotoxic? Drug-induced liver damage has more severe clinical consequences in patients with hepatic impairment. Therefore, if a non-hepatotoxic drug is available, this should be used in preference. 8. What are the side effects of the drug? Potential side effects of the drug need to be considered in light of the patient's current and potential problems. For example, a patient with decompensated cirrhosis may not have signs of encephalopathy, but the use of a drug with sedative side effects may precipitate its development. 9. All patients with severe liver disease who are taking drugs should be monitored carefully. It is important to prescribe simple regimens and to avoid drugs that interact. The consequences of interaction may be more severe in these patients. Patients should be informed why the drug is being used and given instructions to contact the doctor if they develop adverse effects or their condition deteriorates. 10. Is the drug a herbal agent which is hepatotoxic? Herbal hepatotoxicity is increasingly being recognized, e.g. kava, black cohosh, producing a range of liver injury and potential for hepatotoxicity herb-drug interactions. We will now discuss the clinical pharmacist's role. Clinical pharmacists working in secondary care are suitably placed to consider the effect of medicines on the liver. Pharmacists will 1. Monitor different forms of liver disease and advise on the drugs used in their management. 2. Advise on drug dosing in liver disease. 3. Consider drug-induced liver disease where patients are admitted with liver dysfunction, ensuring that an accurate medication history is obtained when patients present. For patients, pharmacists can provide information on medicines and their monitoring, and prevention, vaccination, needle exchange schemes, measures against transmission of viruses, abstinence from alcohol, and promote health in liver disease, reduce alcohol intake, increase exercise. Thank you.